Myślę, że powoli możemy zaczynać, drodzy Państwo.
Right, it looks like we can start. Ladies and gentlemen, thank you for the invitation. I am Marcin Lepo, and on a daily basis, I'm a sport journalist at Polsat Sport. So the topic of this conference is actually also quite important to me. Actually, one of the gold medal winners, a famous athlete, told me some time ago, it's ever more difficult to find children and to motivate them to practice sports. And the young candidates are of ever worse quality looking at future sports accomplishments. And we are just talking about a marginal group of children that in the end will train to have a chance in international competitions. And today we will try to address all of the children. So this topic is also quite close to my heart. I'm a dad of 2, and Leon, as it happens, is 8 years old. And that's precisely the target group that we will discuss today. With us we have Beata, who told me that she also has an 8-year-old child at home. So health of children in Poland 2021-2025, knowledge that can change the practice. That's the topic for today. Thank you very much. And now the official opening will be carried out by the Director of the Institute of Mother and the Child, Alicja Karnej. Hello everyone. Ladies and gentlemen, welcome at this international scientific conference entitled Health of Children in Poland 2021-2025, knowledge that changes the practice. And I would like to welcome our guests. We have representation of the Ministry of Health, Mr. Tomasz Maciejewski, the representative of WHO's office in Poland. We know that we have you, madam, substituting your colleague, Beata Małecka-Libera, senator at the Polish Parliament, chairperson of a commission for children, will join us later. Mateusz Łach, director of Department for Planning at the Ministry of Sports and Tourism. Well, I can't see him. Maybe he will join us. It's not that easy to reach some destinations in Warsaw today. Anna Baszko, director for Public Health. Joanna Wich, from the Commission of Health at the Polish Parliament. She has not joined us yet. Remotely, Julian Williams will join us, representative of WHO, the European Office for Prevention and Control of Non-Communicable Diseases, and Helena Koliżan from the Croatian Institute of Public Health. Ladies and gentlemen, I'd like to welcome all of the directors and heads of hospitals, experts, researchers, lecturers, and our speakers that represent medical institutes and the academia, both in Poland and international. Also, I'd like to welcome school nurses. They will have a huge contribution to carry out the projects that we will discuss. Plus, without them, those study results would have never been achieved. Also, I'd like to welcome the media. After all, the media support us in disseminating reliable knowledge on public health. And for years, they've been helping us to educate the entire population. And finally, let me welcome all of you, ladies and gentlemen. Your presence here actually highlights how important it is to take care of the health of our children, future generations. Today we have the opportunity to present study results and discuss challenges that we are still facing. It's also about working out practical recommendations that could improve the health of the youngest and a bit older children. I wish you fruitful deliberations and welcome here at the Institute of the Mother and the Child. Thank you very much. And now the co-host, Professor Anna Fiałkowska, will take the floor. She's Deputy Director for Science at the Institute of the Mother and the Child. Over to you, madam. Ladies and gentlemen, thank you very much. If you allow me, I'd like to mess up a little bit with the agenda, and I would first ask Mr. Tomasz Maciejewski from the Ministry of Health to have some opening remarks. As you know, the position of the minister is the position that requires some dynamic alignment to the time that the minister has. Thank you very much, ladies and gentlemen. I feel here like I'm at home, actually. As you know, it's from here where I jumped over to the Ministry of Health. So public health is something that should be based on well-designed population studies. The Institute of the Mother and the Child has been carrying out such studies for 50 years, specializing in children and adolescents. That's the target group of ours. And I'm sure we will talk about that a lot later on. Well, in our region, the main problem is wrong body mass, mainly overweight and obesity. Recently, however, we also see some new phenomena, which is deteriorated well-being of children in the form of disrupted rapport with peers and wrong digital skills or digital consumption of the media. That also impacts the family life. If you take all that together and add on top of that little physical activity and poor diet, being bombarded by digital stimuli all of the time, because that's what many of our children are exposed to, that brings many challenges to prevention. And today you will learn all of the details of the report that was conducted as the NOPL study for 5 years. Its diagnosis of intervention of blood hypertension and obesity, to look at diagnostics in children at the beginning of primary school, including lab and genetic tests. Now, it was quite challenging to come up with a modern prevention program based on the studies. And that's one of the points of this conference, in fact. We would like to get some practical insights into how such programs can be designed. The experts we invited will share such insights with you to make a difference. So I also wish you very effective collaboration and exchange of views, so that in the end that can translate into improved health of children and teenagers. And well, let's be realistic, it won't happen overnight. It will take many years to come. But this is the beginning. And hopefully what we start today will bring fruit in a couple of years. Hopefully out of those young children and adolescents, we will have healthy adults in society, so that the society as a whole can be healthier and spend less on treatment. Thank you very much. Right, so could you please show my presentation, ladies and gentlemen. Warm welcome from me as well. I'd like to welcome all of my friends, fellow experts, including the national consultant, Professor Belwicki, and all of you, ladies and gentlemen, that were involved in the program. You will see in just a moment that there were many people involved and many people made a contribution to make it happen. So that program diagnosis, intervention, hypertension and obesity can change some practical realities. Now, I'm referring to WHO's office, European headquarters, and the Polish one actually, because the main diagnostic element of that was to carry out the project called COSI. So it's a project called Childhood Obesity Surveillance Initiative. Over 40 countries all over the world now take part in COSI, where they look at obesity and conditions in children between the 6th and the 9th year of age. You will see that in Poland we focus mainly on 8-year-olds. And all in all, we tested several thousand children starting from 2019. That was the very first COSI round that was organized here. And what exactly can we say after that period? The first report was published in 2016, devoted to overweight and obesity in 8-year-olds in Poland. And here, at this point, I'd like to refer to someone that really made it happen at the Institute. It's Professor Anna Oblacińska. She is the main driving force of this project and of school medicine. Ania, I hope it's okay for you that I now officially thank you for your contribution. Subsequent ministers of health, I always told them that Anna Oblacińska is a great source of knowledge on the so-called school medicine. So she's a very valuable expert. Now, thanks to Madam Professor, that project could be implemented in Poland. It's due to her skills and knowledge to also coordinate the project that was possible. Then further subsequent rounds of COSI were rolled out, and in the end, the one in 2022-2023, after which another report was published. Now, the results of the report will be published in a moment. First, let me say this. Indeed, starting from 2016, the first COSI round that was implemented in Poland, that was round 4. As you can see, we were collecting knowledge on the health of children in subsequent COSI rounds. However, as early as in 2023, we came up with a Polish cohort of 8-year-olds that were tested in labs. Also, anthropometric measurements were conducted, as well as I said, lab and genetic tests, because we were looking for genetic factors behind obesity, hypercholesterolemia, including the family form of the former. So the first stage of the study was carried out in 2023. And right now, the same examinations are repeated in the same population so that we can compare the results. It's the very first longitudinal studies of that kind in Poland. And finally, in 2024, we looked into the results, whether we were asking correct questions on physical activity. And Anna Dzielska will then take the floor. She will tell you more about that program. She will share her results, and I will also tell you what our insights are on the quality of sleep. And in the end, we tried to translate that knowledge into coming up with modern prevention program. The first one was a program for young children in the time of coronavirus pandemic, and then High Five, przybij piątkę, that was a program targeting children aged 7 to 9. And in 2023, we carried out a pilot study We will share the results with you because they are quite encouraging, they are quite optimistic. They demonstrate that yes, it's possible to influence children in early grades when it comes to changing some routines. And this year, there are more schools that participated in the program. So we will be interested to see whether that was efficient or not. It's the first randomized longitudinal study in Poland. So knowledge that changes the practice. And now we will listen to presentations. We have planned some debates with experts with you because we will share the results, but then we would love to hear from experts what is their take on these results. Thank you very much, Professor. Thank you, Minister. Thank you, Madam, for opening our event. Now, some housekeeping. As you heard from Professor, the meeting is divided into 3 thematic blocks. The first 2 will be led by Beata Pieniądze-Gosińska, my dear colleague actually, a journalist from Rynek Zdrowia. She will then also moderate a discussion with experts. The session number 1 is entitled Prevalence and Conditions of Overweight and Obesity in Children in Early School Age. We heard already an introduction. Julian Williams will take the floor in a moment. She will join us online. And those of you that would like to listen to the translation into Polish, we have such a possibility. And you can grab headsets or ask someone to bring you these headsets so that you can listen to the Polish version. The second block is called Biochemistry and Genetics in the Evaluation of Polish 8-year-olds, What Surprised Us. And the third panel will be led by me, and it will be about efficient prevention in children in early school age and how to ask about physical activity in population studies. So these are the 3 blocks that we've planned for you, and I think we can start with the first one. Professor? If I may, I'd like to ask for my presentation to be showed now because I would like to share with you the results of the subsequent COSI round and the outcomes of our studies looking at the field starting from 2016.
So why do we deal with overweight and obesity at all? A short forecast till 2050, published in Lancet journal a while ago, and I highlighted our geographical level, region, and both will increase obesity and overweight in the age group between 5 and 14 years of age. And the question is, can we do something about it? Well, why should we? Well, longitudinal studies show that obesity and overweight in children is a predictor of disease in adulthood. And diabetes, you can clearly see here how strong a risk factor it is in children. Then ischemic heart disease, stroke, but also hypertension. And these are data published a few years ago from longitudinal observational studies. So we're dealing with it. And this is what COSI did. This is an international research project assessing obesity in children in the age group 6-9. At present, in the last round, 37 states were involved, 500,000 children were studied, including Poland, 4 rounds, and then there is a uniform protocol and methodology aimed at collecting information about children's lifestyle and familial obesity and overweight, because parents are included as well. And we studied more than 10,000 children in Poland. And in this school year, 22-23, we studied not only 8-year-olds, but 7- and 9-year-olds, antedating and including their parents. And a lot of people in this room know that assessment of obesity in children is not that easy as in adults, where we have BMI between 20 and 25, which is correct. Here we talk about Z-score, deviation, standard deviation from median. From deviation from average for the population. And the most important criteria come from WHO, and they were used in this project as well. What did we find out? The first populational study that was carried out by the Children's Health Center in the years 2007-2009. And if you excluded 8-year-olds from the project and added COSI from 2016, 18, 22 and 23, you will see boys and girls. And you can see a continuous increasing trend for average BMI. And the same applies to waist circumference. And in fact, these are not data that would be satisfactory, because in recent less than 20 years, this is what we've been observing. And frequency, so prevalence of obesity and overweight in 4 COSI rounds. In COVID period was the worst, when 35% of 8-year-olds had incorrect body weight. In the last round, it's slightly better, but if you excluded 2021, you would see a continuous growing trend. So this means 1 in 3 boys in Poland and 1 in 4 girls in Poland have incorrect body mass, and 1 in 5 boys are obese, 1 in 10 girls are obese. So these are data that require analyzing, and they require an intervention. Also of concern is the first round that we carried out this year in those 3 age groups, and from 6 to 9, in the group from 6 to 9, the prevalence of incorrect body weight has been growing, 35% 9-year-olds. And this is a very concerning phenomenon. And the same applies to obesity, unfortunately. And HBSC studies told us that in adolescents, the prevalence has been decreasing, but as I said, it's a predictor of morbidity in adulthood. We were the only country involved in COSI which measured pressure. And referring to studies of Professor Litvin and Wadi in OLAF study, we compared average systolic pressure, and it, especially systolic, but also diastolic pressure, has been growing. It's higher. I'm not talking about hypertension, but average diastolic tension has been growing. And what is very concerning is that we've seen a systemic increase in the rate of children with incorrectly high tension. So we do not identify here hypertension, but we are talking about incorrectly high tension determined during the studies carried out by school nurses. So my last remarks, and one of the last elements, sleep. Well, this is a well-known risk factor, so for incorrect body mass in adults. But once we analyzed data for 2018, we saw that it's an important risk factor, especially in 8-year-old boys, but also in the case of girls. So a study with accelerometers, where we were trying to look at physical activity. This was methodology which measured length of sleep. And for 8-year-old, it is recommended to sleep 9 hours a day. And this flat orange geometric figure. These are children sleeping 9 hours and longer. It's 1%. 1%. 99% of Polish 8-year-olds sleep too short. And, well, how come? Please note that sleep without waking up accounts for only 7.5 hours a day. And we studied more than 500 8-year-olds. Sleep with waking up, that's less than 9 hours, and waking up accounted for 1.5 hours, which means incorrect sleep hygiene, which translates not only into increased risk for incorrect body mass, but also it has impact on lack of concentration and emotional disorders. Food habits, nutritional habits. This is a never-ending story, actually, about the necessity to eat breakfast. And 1 in 5 students in this age group do not eat in the morning. Only 1 in 3 pupils eat vegetables every day. I don't know what these children are eating. And 1 in 2 pupils eat fruit. 1 in 5 boys and 1 in 7 girls do not eat a single vegetable or fruit. And in turn, 1/5 drink sugary drinks at least once a day. That's 20%. They are children aged 7, 9. And 1 in 10 use sweet snacks and sometimes salty snacks. So these are incorrect nutritional habits. To sum up, what do we know from COSI rounds and the study with accelerometers? Obesity on overweight in Poland has been growing, and that's a significant problem in primary school children. We see also a slow increase in the percentage of 8-year-olds with abnormally high blood pressure. And children's eating habits need to be improved, primarily by increasing their consumption of fruit and vegetables and sleep. And this is a new phenomenon that we were able to identify. Dr. Zielska is going to present further analysis. And preventive programs tailored to different age groups of children and Polish teenagers are needed, aimed at changing their lifestyle. And we are going to show that we can do something about it. Thank you very much for your attention. And meanwhile, I'd like to thank very much a person, thanks to whom, ladies and gentlemen, it was possible to create this project. Minister Tomasz Maciejewski. I always say that he's the boss who seldom says no. Thank you, Professor. My boss does say no, but he's not so bad. Well, ladies and gentlemen, this was the first presentation and an introduction into the first discussion panel, but we still have one more presentation, summing up and presentation of health behavior of children in the light of most recent COSI studies. I hope we are connected.
Welcome.
Thank you very much, dear colleagues. It is an honor to be at this event today. My name is Julianne Williams, and I'm a technical officer for obesity in the regional office. And I apologize, I am having some technical issues, so I will keep the camera off for the presentation just to keep us connected. I would like to thank specifically the WHO country office, Poland, Dr. Nino Bergsky, and our co-clinical investigator, Professor Kielkowska, for her leadership in COSI. I'm getting a bit of an echo in this presentation. Is it possible to stop the echo? Maybe I'll just continue. Okay, thank you. In the WHO Child Obesity Surveillance Initiative, where Poland is a part, We are doing some new work to validate some of our indicators, and we have relied on the scientific expertise of Professor Fialkowska and her team, and we are so grateful for her leadership. I will be speaking very briefly about the results from COSI round 6, which we have just released. And this should give you an idea of how Poland compares to the other countries who collected data. And this represents findings from around 500,000 children across the WHO European region. Professor Fialkowska has already described the details of COSI, so I will save time and not go into details. I will start with just saying the summary results show that around 1 in 4 children in our region is with overweight and 11% with obesity, contributing to non-communicable diseases and premature mortality. And from the latest results, you can see there's very wide variation between countries in terms of the levels of overweight and obesity. We tend to see higher levels in the Southern European countries and lower levels in for example, in the Central Asian countries. You'll see Poland, I've put a star there, where you are on the higher side for overweight and obesity relative to the other countries. Similarly, with obesity, higher levels, especially in Southern European countries. This slide shows just levels of obesity. And we see a striking sex difference. In almost all countries, the level of overweight is higher among boys and lower among girls, and that's the same for obesity. We asked in round 6 about the parental perception of childhood body weight, and what we found was that most parents did not recognize that their child was with overweight or obesity. So when we asked parents of children who were with obesity and overweight, did they recognize it? Most of them for overweight did not, in many of the countries, including Poland. And so this suggests a policy opportunity. I appreciated our chair's mention of 8-year-old children. I also have an 8-year-old son, like many of you, and so this issue is also dear to my heart and has a special relevance. Professor Fialkowska has already talked about the low levels of fruit and vegetable consumption that we found in the region. Actually, we found that only about 1 in 19 children in the countries where we collected it is eating the recommended levels of fruit and vegetables. That's just 5% of children are getting the recommended levels. And this was, I think, a surprising result for all of us. Many children, less than half, eat fresh fruit every day, and less than a third consume vegetables every day. And alarmingly, we saw that it was worse among children who had lower levels of parental education. We also found high levels of sugary soft drinks. You'll see here Poland had somewhat frequent consumption of soft drinks relative to some of the other countries. And we found that breakfast consumption varied a lot by countries. Around 25% of children did not consume breakfast daily. And again, it varied a lot. I'm calling you from a hotel in Tbilisi, where we're having a workshop now with Georgia. And this is one of the findings that we'll be discussing today, the low levels in Georgia, for example, of breakfast consumption. But for Poland, you'll see you're kind of in the middle in terms of the levels of breakfast consumption. We also collected data on active travel to school. Around 53% of children in the study traveled actively by foot, bicycle, or skating. And this can be an important way to get physical activity. We are working with Poland and with the other COSI principal investigators to validate our measures of physical activity. This is parental report. And there's some question about the validity of these measures. For example, we asked, do children spend an hour a day playing actively or vigorously? And you'll see across the board, most parents that say yes, they do. And I think further work is needed to assess the validity of this measure. Similarly, we measure screen time, and we find that overall, around 42% of children spent at least 2 hours a day watching television or using electronic devices on weekdays, and that increased on weekend days. So I would again like to thank you very much for this opportunity to participate in this important conference on turning our knowledge and into practice. And thanks again for just the leadership and support from Poland to the rest of the region for the Child Obesity Surveillance Initiative. Thank you.
Thank you so much. Dziękujemy bardzo, Julie.
Thank you very much, Julian Williams, European Office for the Prevention and Control of Non-Communicable Diseases. But thank you very much for your presentation, and I give the mic to my colleague Beata Pieniążek-Osińska. Well, hello, ladies and gentlemen, and I need some technical assistance to elevate the screen. We will have a debate on effective use of data from cross-sectional studies to investigate health interventions. Let me invite Madam Joanna Głażewska, representative of WHO in Poland, director of the office, and Bernard Waśko, director of the National Public Health Institute, Dr. habilitated Professor Sum Paweł Matusik from Silesian Medical University, Professor Dr. habilitated Mieczysław Litwin from this institute, from the Institute of Children's Health, and Kuba Senkowski, Deputy Director of the Department for Public Health, Ministry of Health.
So we've just seen the results. To some of us, they may be quite shocking. We see a rise of the phenomenon, and the reasons behind overweight are not only screens, but also poor diet and lack of physical activity or poor sleeping habits. Professor mentioned that. So what are the three most important conclusions that you think should be the key takeaways from these outcomes and that should be included in the current policy? Dr. Waśko, could you start? Well, the first one definitely is that we should have a precise definition of the goals that we want to achieve in terms of the problem and the growing scale of obesity in children, both girls and boys. Well, defining the goals must be realistic. So I think we hope that in the years to come we will at least inhibit that growing trend. That could be the first beacon of hope to then improve the current indicators. So indeed, this will be quite essential for the future life of the children now. They will be adults, so we need to make sure that they have proper eating habits and a proper lifestyle, so that they are not that susceptible to some wrong marketing statements. Well, humans are humans. Our brain likes to have the reward in the form of elevated glucose, and that's what we get after we eat some snacks. But in the end, that can lead to some somatic diseases that then can be treated, such as hypertension, and some secondary diseases such as diabetes and metabolic conditions. Yesterday, together with the colleagues from the Institute and from WHO, as it happens, and the Federation of Employers, we demonstrated a long-term forecast showing the difference, the discrepancy between the costs and the actual results in the healthcare. And we looked at the year 2040 and 2060. This is quite ahead of us, but that's the two dates that we looked at. So when you think about these numbers, we decided to express that in percentage rates vis-à-vis GDP or per capita spending. And one can draw the following conclusions. The as-is scenario, where we do nothing and we just stick to the current trends, will lead to a scenario that can't be accepted by any society economically. Therefore, we need interventions into public health whose rate on return will be 4 to 1 or even a dozen to 1, because we have such options of conducting activities that will give us such a huge rate of return. But the problem is that you need to be patient. You need to wait to see the results. My colleague from the Employers Federation yesterday came up with a unit of time measurement called cadence, cadencia. So with that, looking at the demographic changes until 2040, it may sound abstract, but it's just 3.5 cadences away in his terms. So cadence means probably term of office, like of a minister. So hopefully we will be able to all join our forces, because this is necessary for all of us to stop these trends. I guess we can talk about more details in a moment. Yes, 3.5 terms of office. I don't know whether we have that time looking at the quick pace of development of obesity in children. Now I'd like to ask Madam Łażewska from WHO. Is there anything that surprised you, madam? Are there any countries that are doing better than others? Well, let me first go back to the previous statement by the director. Indeed, there is the light in the tunnel. We are talking about some interventions that require decades to see the results. But in March this year, Lancet published a quick bias, which is a list of interventions that have already been reviewed and shortlisted to have some factors of non-communicable diseases which can also be addressed in a short-term perspective, like up to 5 years. That would be like 1 term of office. But there are also other interventions whose results are observable even after 4 months or virtually next day. And I will be happy to share more information about that later on. So indeed, we have some states in Europe where such policies have been pursued consistently. And I hope, and I'm very happy that Poland is on the same path. And I had the pleasure to take part in different processes in the last 10 years on the design of most efficient interventions, such as dialogue or proper labeling of food. here discussions are running which European system is the most efficient one, so that there is proper designation of food and so that the consumer is not misled. But we need this badly. Now, a second type of intervention that I'd like to mention, which is the case, for example, in France, Italy, the UK, but also Portugal. And actually, it's Portugal that I want to focus on. So Portugal has been very consistently implementing several policies at the same time. On the one hand, it's proper labeling of food. On the other, it's promotion of physical activity, but it's also about raising awareness and educating society in its entirety, not only children. And here are coming back to the question that some of us find shocking, which is, indeed, there are some economic disparities also in health. So the percentage range of children that are affected by obesity and overweight is related and corresponds to the education level of their parents. Full stop. Thank you. Yes, I'm sure there will be more opportunities to delve deeper into some of the points you mentioned. And now, the representative of the Ministry of Health. What is the greatest barrier in such initiatives? Is it about funding, or is it about creating proper health culture that I think should be built from scratch? Hello, ladies and gentlemen, that's me again. I will be happy to refer to previous statements. To me, one of the most practical takeaways from the study is that you can topple certain myths on what is the reason of the phenomena that we observe. And director referred to some cliches or some conspiracy theories in society. Well, in this study, we have very clearly pointed out reasons, and that forms the great basis to now engage in good communication with society. WHO calls for that, to have proper communication. What is shocking is that the awareness of the problem in parents is just so small. Parents seem to fail to notice a problem of such a huge scale. It's like the elephant in the room. So these two, pointing out the real reasons and pointing to where the problem is located. But it's not about blaming anyone. Some people say very easily, oh, the parents should be blamed because someone is poorly educated. They can't educate their children. So I think we should... I used to work for the prosecutor's office, but I think blaming is not the way in which we should go. So we should never talk about blaming anyone, because blaming would only be possible if someone did things deliberately. We know that these parents were not educated themselves. They were never prepared to face the changes that we see in this century. That's why we need to design wise programs to counteract those false narratives that we see. And we need to make sure that that mistake is never committed again by future generations. Now, coming back to your question, madam, is it about people or is it about funding or culture or coordination? Well, actually, in Poland, well, we are an affluent state. We do have the funds. We can't say we don't have resources. It's about allocating the resources in a proper way. So you need to take into account all of the reasons, all of the elements, and connect all of the dots. It's not only about prevention or early diagnostics. It's also about promoting healthy choices, so that healthy choices are not heroic, but rather they are choices by default, the easiest ones, economically speaking. So talking about the resources that we have at our disposal, we do have them. The problem is that they are poorly allocated in the system, unevenly allocated. So we need to make sure that the resources are spent for promotion, of health for prevention. And the way we do it right now is not the right way to go. Apparently, 6 billion zloty is the sum of money that we spend every year for prevention and promotion of health. Well, have you ever seen the money? I'm telling you that because I read that in some reports that I read at one of the self-governments based on the Act on Public Health. So it seems there is no proper coordination. And what struck me, it's a sports metaphor really. Well, I feel here like in the temple of Hera, in where the Olympic fire is first lit. So why do I think about this metaphor? The study that you referred to, and we will keep discussing it, actually demonstrated to us that things can be done in an efficient way. The problem for us is to dream bigger, to see the big picture. So it seems that at some point we fail. Like, for example, it's about disseminating some interventions. There are some barriers because we have a solution, but once the solution is to be rolled out in other sectors, something fails. Right. So is it about this diluted responsibility, maybe? Well, we still have some time, so it would be great to know the... Actually, no one questions the fact that we need to cooperate. It can't be just one body. Well, yes and no. Indeed, every minister also should run a health-based policy. Not just the Ministry of Health and the other ministries don't think about health. No, each of the ministries have to think about health as well. However, that means we need to be well coordinated. In the EU, people say the EU is not an international actor because there is no one contact person whom you can call from the EU. And I think the same applies to future health. You don't have just one contact person that you can phone, that you can call in the future, because you have different ministries that are involved. So obviously, you can always call us and my department. I'm looking at Bernard. But the problem that is quite visible now is lack of leadership. And indeed, the Act on Public Health is to be amended. Yes, I heard some news about this, but off the record so far. Right, and now Paweł Matusik from Silesian Medical University. Tell us, please, sir, what you believe to be the greatest barrier in implementing efficient interventions. Well, I'm afraid there is not just one barrier, but more. If you allow me, I'd like to first refer to some previous points. Well, I am not shocked by that report, to be fair. I've dealt with that problem starting from the year 2000. And I remember the data from 2002, and it was about the same age group, and we had 15% of children that were overweight or obese. So now, after 20 years, these figures doubled. And I'm so happy that we have that great meeting today, that WHO and Poland joined their forces. But knowing about the problem and the fact that it was growing is not a new fact. And also the factors behind it are not new at all. On the other hand, I know that the goal is to reach out to more people in society. But what we see here is just a section. Obesity and overweight in children is like a vicious circle. Every population, starting from women that are prior to pregnancy and then newborns and others, we see many risk factors to develop obesity. So there are many points where you could undertake interventions and carry out primary and secondary prevention and then treatment. So indeed, we should make a phone call to the ministry, because when someone already has a disease, it's too late. You have to treat them. You can't just talk about prevention. What was not shown here in the study, it was WHO. You couldn't grade obesity, but we have actually 3 grades of obesity. And sometimes we see different fluctuations here in these grades. We have more and more children that have extreme obesity. 15-year-old adolescents come to me, and none of them sometimes weigh less than 100 kilograms. So this is a very serious. You mentioned rolling out the best practices. I don't want to stir that discussion up too much, but think about health education. The way in which it was prepared is something very different than the way in which it was implemented. That could open up another discussion, I think. So you could actually multiply such examples. So we have great ideas. The problem is when we need to implement them. It's not only about parents, it's also about specialists, it's about experts. In the report of NIC some years ago, it was about primary healthcare units. It's about how frequently GPs are able to recognize and detect obesity. It's like 1%. It's like in Africa. So I think now is the time for each one to admit that we all have a say in this process and that we all need to improve. And just like you said, talking about methodology, when we meet, in fact, it turns out that yes, there are ministries running their own programs, but sometimes they overlap. They spend money to pursue the same goal. We should rather focus on coordinating that so that things are implemented in the form of a package, like first through a pilot program, and then it should be included in the service basket. We don't have a patient journey if they are obese, for obese patients. Thank you very much. Professor, and how would you comment on the data? Thank you very much for showing me the data. And indeed, to be fair, I am not surprised, because those people that deal with such populations do realize. Maybe we thought the percentage rate was a bit smaller, but we know the phenomena. So I am a clinicist and a pathophysiologist, so I rather deal with consequences where people develop metabolic syndrome, hypertension, or something new, which is heart, kidney, and metabolic disease. And it seems that in the whole population, blood pressure rates are now elevated. And if so, that explains a lot. When you analyze the reasons behind hypertension, and I have some data from 40 years back, my supervisor carried out such data, such studies. 40 years ago, that was in the years 1980s. They couldn't find even a single case in children. And then, after some years, we see hypertension in children as young as 3. And these two are very much interrelated. Now, thinking about why our interventions in prevention and in other areas, why are they not as efficient as they should be? The reason, well, we need to go back to what Professor said, which is health education. Our message has to be comprehensible. So sometimes we formulate our messages in such a way that the other party can't understand it. Health education should be addressed at children. And in fact, we expect that those children that are well educated now in the future will be able to pass that knowledge on to their children.
Speaking of patients in our clinic, we have a problem with scales. Our beds and scales are not adapted to the patients. And these families are not a genetic, do not have a genetical problem, but these are lifestyle diseases. So our message has to be adapted to them. And one more problem. Specialist medicine has changed. Arterial hypertension and obesity are one of the most frequent diseases in adolescents. 10% of adolescents have primary hypertension. And this means then in specialist education, we need to focus on that. We need to focus on obesity. We are not learning how to treat obesity. So there are several measures here. And as has already been said, it cannot be a single measure, but it has to be a broad spectrum of measures implemented at once. Health education is the most important. Our messages have to be understood. Coming back to clinical practice that you mentioned, how does populational data translate into real patient needs in clinics? What do patients approach you with? Because it's not yet hypertension, but already too high a level. So what can you offer to such a small patient who's not yet sick but has a problem? Well, the whole package of measures that we refer to as pharmacological treatment, and it applies to hypertension. It's already hypertension. On average, the frequency, the prevalence is 5 to 6% in the population from 0 to 18, but the peak is in pre-pubertal age and that after puberty. So this is a public health problem. What measures are we taking? Well, we refer to it as non-pharmacological treatment, and it boils down to healthy lifestyle. Everything that we talked about that we should teach during health education: how to eat, how to sleep, how to spend free time, not to watch TV. Trivial things. I'm not going to repeat them. And efficacy is very high of these measures. We have 6 studies, prospective studies on hypertension and primary hypertension, primary obesity, visceral obesity, metabolic syndrome. Year-on-year efficacy of normotensity is 80%. Regression of organ damage is 70%. So it's an effective measure, provided that the other side, the patient, works. So these have to be multi-sectoral measures, not just measures of doctors. We're talking about coordinated care and cooperation of the whole team. I don't want to put the burden on the Ministry of Health and doctors. We're talking here about behaviors, and I have my doubts. It's determined by culture and socioeconomic factors, both OLA and OLAF, that we carry out, as well as COSI. The socioeconomic status does matter. In our study, OLAF, the most important was mother's education. And father's education, it seems, does play a role. As doctors, we need to be demanding. We need to know what to do. But socioeconomic, cultural factors, we have no impact on them whatsoever. So it's not just the task of doctors. I was thinking about advice, educational advice that could be given to parents. I'm afraid it won't solve the problem because we are talking about an intervention among millions. So I would talk about schools here. We start early in preschool and school. Definitely we will talk about schools because we are going to talk about program that did work. Doctor, you wanted to comment on populational data? Well, actually, you've already mentioned it, coordinated care, and I agree with Professor that if you look at the population, the topic is much deeper, and it's a measure of education and knowledge. But coordinated care from a point of view of our functioning in clinics, it's a new solution, but it requires extending to make sure obesity diagnosis gives us the possibility to refer to other specialists on the team that supports us. Because honestly, it might sound paradoxically, but if you have obesity, to refer this patient for coordinated care, they have to have complication like arterial hypertension. Only then does this path open, and it's not a good thing that we are waiting for what's going to happen. But I think we are working on it to make sure obesity is a cause for referral. Because doctors are doctors, it's one thing, but it's therapeutic teams, psychologists, physiotherapists. It's not just a doctor, because this is a too complex a disease to handle it but by one person. So staff is not fully prepared. Healthcare workers are not fully prepared to deal with the problem. The system actually is not ready. It's not organized to make sure that these people can get engaged. So we have a partnership, Stop Obesity, which associates a lot of stakeholders in this area. And an analysis of curricula was carried out in curricula in university, devoted to university, to obesity. And it all depends on the university, whether they have experts who can offer lectures and convey knowledge. So we are going to propose a pilot subject to universities called obesitology, and we'll see how it goes. Maybe we will be able to make sure that this topic will be included permanently in the curriculum. I keep talking about specialists and doctors, but it also applies to different schools of higher education which teach this subject. It's not that nothing is happening, but this area needs to be coordinated and changed. Thank you very much. Now, if you were to point to a single intervention with the biggest potential, what would that be? Starting with you, madam. I'm not going to indicate a single intervention. It's wrong to think that we will repair the world by means of a single isolated measure. And we talked a lot about healthcare system. And let me refer to the environment. The patient leaves the doctor's office, and let's say they went to 5 different doctor's offices. Then they go to eat something. They watch advertisements. They make choices every day that have impact on efficacy of therapy. So best buys. I will keep readdressing that, because this is effective, an intervention package, and it should be implemented as a whole. And there are 3-4 interventions here. So labeling of food and reformulation. So labeling in itself without additional reformulation will have less impact. And again, Poland is on a good pathway. One of 5 countries all over the world that got WHO certificate for eliminating trans fats. And in Georgia, this meeting concerns eliminating trans fats in foods. And another thing, and we didn't talk about it today, commercial health determinants. I mentioned social and economic conditions and mother's education, but the choices we are making on food, nutrition, behavior, physical activity, risky behaviors, using psychoactive substances, legal or illegal. So it's a consequence of the stimuli, also commercial stimuli that have impact on us. So commercial determinants of health are also important. Thank you. Director? I keep calling you. Yes, we always call back. Yes, I'm calling you with a question. Is there a single thing. I fully subscribe to what Jasia said. It's, in fact, the way the question was formulated, like, let's do something quickly to show success, how successful we are. Well, in healthcare, it's not the way it works. And we need to remember that. Is there anything that we should start with, something that would be the most urgent? This is what I was aiming at. To follow up on what Doctor said, I fully subscribe to one thing apart from one. Over the past dozen years, nothing's changed. The indicators have worsened. Well, a lot has changed, especially in the area mentioned by Joanna. There are special tools, aggressive marketing, digital targeted marketing. This tool was not in place before, and biological determinants did not change over a decade. It wasn't possible. These are trends which are long-term trends. But as regards the tools that are available, and well, it's a huge change. We've seen a huge change. So if it changed, and we have a populational effect, let's define priorities in such a way so as to find a vaccine to new threats that occurred recently, because this wreaks havoc and in children's behaviors. So if we were to choose anything, and if we were to prioritize, we should be able to measure it. Now, if we only have tools such as interval study and COSI study, it's very necessary, but today we could have much better tools. Like COSI, that works in real time throughout the whole year, for many years, covering not samples, but the whole population. So, in other words, you use health balances in healthcare, and we use the data in our internet patient account. They are processed, anonymized, and analyzed real time. And then we can assess whether the intervention we took works or not, because now we use our intuition. It's great to learn based on someone else's experiences and implement those quick buys, but we have different phenomena with different intensity, and evaluation is key and immanent feature of a good prevention program, and it has to take place. There has to be a starting point, there has to be an intermediate goal, and what happens afterward, and modification. So we, ladies and gentlemen, we created a project that we presented together with Professor Fiałkowska, who's now giving an interview right now, and Professor Jackowska, digitalizing this part of internet patient account and call it a digital health book of a child with all data, not just balance carried out in specific age groups according to the law, not just vaccination according to the vaccination schedule, because we already have a digital tool for that, but paradoxically for 3 years it's been obligatory for non-obligatory vaccinations. And 25% of non-obligatory vaccinations are implemented into the system. So still, we know nothing. And Minister Grzesiowski, when he had to investigate the vaccination rate of children in spring, it took several months. He engaged several thousand employees and analyzed 8.5 vaccination cards and 45,000 vaccination cards to generate results which are incomplete. So in the era in which we have tools and internet patient account was implemented, and it has a huge potential. So let's release that potential of data to assess intervention outcomes, whatever they are. That's the slogan of ADS directive adopted in 2024 during the last parliament session in April. So let's implement that directive. Thank you, Doctor. Maybe you misunderstood me. I didn't mean nothing's changed. Only I meant to say that obesity is still a big problem, and the factors that implemented it, that impacted it, well, there are a lot of them. And it's obvious that we have a totally different environment than 10 years ago. That's clear to me. And I agree with you that this is a key intervention that might result in the fact that we will be able to measure what's happening and document that it's worth spending money on. Because however you look at it, you have to document it through cost effectiveness and through studies. So maybe access to data will allow us to obtain funds easier. Electronic health book is a great idea, and electronic pregnancy card would be a good idea as well, because we as neonatologists and pediatricians would have a tool at hand. Yes. So sometimes good ideas are killed by some minor things, but when it comes to other measures, because I keep talking about treatment, I would like to focus on this period before conception, because it's an important period, and this group of people, young adults who are planning to have kids, and this is the moment to implement preventive measures and to talk to these people and explain that if they are sick, then this is not inheriting, but it's a matter of things that program children metabolically and increase risk in children. As regards children's populations, we know that the sooner the better. It's easier to intervene in formalized structures such as school and preschool, and it does work better. But the most important thing is longitudinal observation, and this is something that takes time, because then data is evidence-based medicine. These cannot be like annual interventions, and that you know that after a year the child lost weight and had a dietitian 5 times a week, and we are showing great results after a year. And so you all know those studies, 26 hours yearly. We should spend 26 hours yearly per patient with obesity to make it work. There is no system that would be able to finance it and support it. The Americans were introducing it into their algorithms, and they are not able to cope with it. So sometimes we are going in the wrong direction, and cooperation with such institutes as yours is very important. And also it's a matter of funds, like sugar fee and the billion PLN that should be paid each year. So these are the funds that could potentially be reallocated to the measures mentioned by Director and you, Madam, in the area of health prevention. Yes, by all means. Thank you very much, Professor.
Any intervention that you think is most pressing? Are you able to identify it? Well, I can't give you just one. I will just reiterate what previous speakers said. Namely, we need multi-profile actions. Only such actions can be effective. So I'm coming back again to health education and looking at specialized medicine areas. When you think about a doctor who has to treat a patient with complications, well, we need to expand specialized programs. We can't flee from pharmacology. Such therapy is sometimes necessary, and it's sometimes not foreseen. And that's one of the most common population diseases. So I will reiterate, let's start from education. Only then should you think about any changes. It has to go from different sectors, and it can't be just the task of the medical sector. Thank you very much, Director. Well, we had some difficult topics here, like the sugar fee, and indeed the money from the fee doesn't go directly to prevention, does it? Well, we are turning to some political topics, I'm afraid. Indeed, sugar fee. I am just a regular clerk. I avoid big politics unless it's about health. But I will try to answer the question that you posed. And I agree with all of the points raised so far. So interventions have to be carried out at all the points during the course of the disease. So whatever you can do, you prevent. And health education, indeed, has gives us a chance to even out some unequal access to information in the society, indeed. And then when you think about behavior, about individual choices, again, we have some tools that we could use. We hope that the ministry will carry out their works. But talking about behavioral factors, well, after all, it's the tools. And the sugar fee is not just about collecting the money, it's not just a fiscal tool, but it's also about changing consumer choices so that their choices are healthier. A regular consumer buys based on the price. Hopefully they will opt for the cheaper option. And we see here the result. Indeed, we see that there is less sugar ingredient, for example, in beverages that are now subject to sugar fee. We need to now make sure that that system is watertight. And now to make sure that these interventions are effective, I'd like to say the following. When you have some target groups, you then have a high rate of return. So it's legislative, regulatory interventions then can give us much more. A couple of dozen% of the return rate. So that can be really record high, like 46 times more money that will be saved. That is a potential result of that sugar fee scheme. So this is an example of how you can influence the behavior of shoppers. However, we must not forget that 9 million Poles have an elevated body mass. And ignoring that fact would be a huge mistake. After all, it's especially males that will probably die prematurely. And in fact, it's males that account for shorter life expectancy as compared to other countries. And we need to take care of them so that they stay active as long as possible. And that will also be a method to cut down the spending and better allocate the money that we have. So we can't let go our activity at any point. No, we have to be active at every potential point. It's 9 million people. Well, of course, we say that we will see the result in the future only, but we can't afford now ignoring these first signs. And we need to counteract complications, indeed. Thank you very much for this discussion. We heard a number of discussion. We heard about some silver lining as well. It won't be easy, though, to accomplish a tangible result. So thank you very much, ladies and gentlemen. Let's give ourselves some applause to our great speakers. And could you now please change the screen? We will need it in a moment. Beata, now take a deep breather, and in a moment we will start the second panel, which is about biochemistry and genetics in the evaluation of health of Polish 8 years. What surprised us? We will have two presentations to elaborate that. Cohort studies of early school children will be presented by PhD medical doctor Witold Klemarczyk. So we need all hands on board today, so that in the end we have some takeaways. Ladies and gentlemen, hello. Being a doctor myself, I'd like to say something which is important from the viewpoint of diagnostics. Let's have a look at these norms here in a bit of a non-standard fashion. Against the background of the discussion that we have just heard and that I listened so attentively. So, ladies and gentlemen, we give credit only to facts that have been verified multiple times. However, let me tell you one thing about this study that I find fascinating. Sometimes people say, you doctors, you only treat those with obesity, in Warsaw maybe only. But please have a look at where these tests were conducted and what was the sample group. To me as a doctor, this is a huge added value. Namely, that study was carried out not only on children from big agglomerations, but rather we have a very beautiful representative sample. And I would like to say once again thank you to all of the nurses, school nurses, that shared the data with us, because this is how we acquired the knowledge about Polish children from across different localities. Now, biochemistry, lab tests, the list is quite long, but I'd like to just elaborate several of them, which to me are crucial. The first is glycated hemoglobin, also wrong concentration of blood in the serum, and we also heard about that syndrome that affects kidneys. And indeed, that's very important. So when you think about obesity, cholesterol is your main enemy. And you see here the total cholesterol, but also triglyceride concentration that are involved in those tests. Also, thyrotropin concentration and FT4 concentration. How come we tested these parameters? Well, doctors that see their patient for the first time hear frequently from parents, maybe something is wrong with the thyroid gland in my child. Maybe that's why the child is obese, so they test. And also, an important parameter that drew my attention is concentration of serum vitamin D. We know that vitamin D is important. There are many conferences on the standards, on the ranges, and whatever magazines you will open, you will see huge advertisements of vitamin D. So that particular parameter interested me a lot. So let's start with the first parameter, which is glycated hemoglobin in blood. Just a moment. So what drew my attention is here, because glycated hemoglobin was also elevated in 3.5% of children that have a regular body weight. So potentially these children might have some other problems, not related to obesity. So maybe we should inquire why that glycated hemoglobin is elevated. Also, creatinine concentration. We know that kidneys play a crucial role in our body. And again, have a look. There is a part of children where creatinine level is not the way it should be. That could mean that their kidneys are not functioning the way in which they should. And by the way, that was visible both in children with obesity and those that we assessed as a healthy group. And cholesterol. We all love it, don't we? And what can you see here? 49. 49 is the percentage rate of those children that had elevated cholesterol. But you can also see some elevated markers in children that are healthy. Their cholesterol also went up. Why? Well, we heard some potential explanations that could tell us what is the reason. Maybe it's because of the quality of food. But I still believe that we should observe these children. After all, cholesterol is something that stays in your blood vessels. It could potentially influence other areas and potentially deteriorate your health as an adult. Now, the so-called HDL, the good cholesterol. As you can see here, you will find it also in those children that have a good body mass index, elevated parameters. So again, let's observe not just that particular group, children with obesity, but let us not ignore also those that look normal and still have elevated results. I think we should be, as doctors, we should be interested in the whole population of children so that they stay healthy as long as possible, so that we can send them to adulthood in the best form possible. The same applies to LDL cholesterol. Well, if you have excessive body weight, in that group you will see excessive LDL. But in children who are qualified as healthy, you may also find elevated rate. So will they in the future, could that predict some future development of their body weight? Or maybe in the future they will be patients of cardiology wards. Similarly, in other parameters, non-HDL or triglycerides. Here the situation is a little better. Still, 29%, almost 1/3 of the sample, were those that still were not obese, and yet their parameters signaled that they had to be addressed. And that's where prevention comes in. And as I said before, sometimes I have in my clinic an overweight child and a mom, and the mom says, I have a problem with my thyroid. And so FT4 and TSH are also tested in children. And in almost all of these children, excessive body weight is not the result of thyroid disease, dear mommy, dear daddy. So let's be aware of that. However, someone may develop a thyroid condition if they are obese and the body has to deal with the excessive body weight. But then there is a different causal relationship. than the one that the patient's parents would love to hear. And D3 vitamin. I mean, pick any TV channel, you will hear a lot about this. There are so many conferences on vitamin D. And these days, you can even check vitamin D and what dose would be optimum for a given individual. And it turns out that in Poland, children don't eat enough vitamin D in their food. Hence, the children that have excessive body weight probably need to be administered with higher doses of vitamin D. No wonder then that they have a lower level and potential deficiency of D3. So that's it from me, ladies and gentlemen. Thank you for paying attention to what I said. I hope I was able to stick to my time. But anyway, let me just show you one thing. This is a photo showing the classroom of my students. It says, "The future of the world is in this classroom." I think that's the best slogan you can think of. The future of the world is in our children, and it's our task to take care of them. Thank you very much. Ladies and gentlemen, we are extremely punctual, so do not worry. And there will also be a coffee break, so you will have some time to refresh and to analyze all of the insights that have been presented to you. That was Witold Kulemarczyk from the Faculty of Nutrition. He presented cohort study results. And now Katarzyna Niepokój, she will tell us more about the word for genetics here at the Institute of the Mother and the Child. Over to you, madam. Hello, ladies and gentlemen. Thank you very much for having the opportunity to speak at the conference, and I must admit that it's not just my work, it's rather the result of the hard work of the whole team of my colleagues at our faculty. And just to refresh, because previous speakers said a lot about this, what is BMI? By the way, do I have a pointer here? So, at the bottom of the slide, I mentioned that it's a genetically driven obesity, whereas secondary obesity on the right-hand side is mainly related with some other diseases. Obesity can be one of the syndromes, or it could be a complication after taking some drugs. And I had such experience myself, but luckily this is reversible. So what are the reasons behind obesity? It's graphically shown here, and I think we heard about all that before. So, the first reason is excess energy intake, eating too much, lack of physical activity, sleeping problems, sleep disturbances, but also certain medications, being subject to stress, and stress is now the new catchword to explain anything, and socio-economic factors. They are also very important.
Moving on to genetic obesity, it can be divided into molecular grounds, or molecular reasons. If a single gene contributes to obesity, it's a monogenic obesity, and if it's the outcome, if obesity is the outcome of many genes, it's a polygene obesity. But also it can be broken down into symptoms. So isolated obesity as the outcome of genetic defect, but also syndromic obesity when it's an outcome of a set of disorders, and there is one such disorder which leads to obesity. among others. And this is a slightly terrifying slide, and on this time axis I wanted to show you that we've been looking at genetic causes of obesity since 1994, and you've all heard about leptin, which was cloned in 1994, and one of most recent discoveries in 2018, that was ADCY3 gene. And I wanted to show you a comparison of monogenic and polygenic obesity. Monogenic obesity, for which individual genes are responsible. This obesity is rare, but it occurs very early, and the genetic component has 100% impact on its occurrence, and the environment doesn't really play a role here. But polygenic obesity is more common, where many genes have impact on its development, and it's more frequent. But the good news is that the environment does matter here, so we can modify it. And if you look at this diagram with red arrow, you will see this gray field, that it's only since 2018 that we started to look at polygenic obesity. These are difficult studies. They require whole genome evaluation, so we needed tools for that. And we are looking here at many genes, and it's hard because apart from these genes, the environment plays a role as well. Now, this is a terrifying diagram. I won't dig deeper into it, but it's leptin-melanocortin pathway in the hypothalamus, and this pathway is responsible for hunger and satiation. And on the slide, you can see genes marked in different colors in different locations. These gene defects are responsible for monogenic obesity, and we know that. This is knowledge that has been verified, and that we know that disorders of any of the genes, these genes cause obesity. And it's like a feedback loop, and leptin is secreted by fatty tissue. Its receptors are in the brain, so it's all related. And if it works well, it's okay, but if something wrong happens along that pathway, unfortunately we have a problem with obesity conditioned by genes. Moving on to studies, the cohort was big in this project, but the consent to molecular tests was given by only 400 parents. So molecular tests were carried out on quite a large group of children, and in this group, 186 children had incorrect level of cholesterol. In 275, they had wrong BMI, incorrect BMI. That's 75% of these children of this group. So the studies, show that that's really a lot of children who have a problem with incorrect body mass. And the group with incorrect BMI and gene variants. So 3 tables here on the slide. The first table shows genes related to monogenic obesity caused by disorders of a single gene. And here we have those letters AR, AD, and VUS. Genetic diseases are inherited in an autosomatic recessive way. So, simply speaking, each gene has 2 alleles. One is inherited from mom and one from dad. Recessive diseases happen when both alleles are or contain mutations. Pathogenic variants are incorrect. In the case of dominant diseases, a single allele with incorrect variant is enough. VUS unknown significance, of which we cannot say it's not significant, but we cannot clearly say that it's responsible for the disease. And in the kids with wrong BMI, all identified variants were VUS. We also have a table which talks about genes with monogenic obesity, and they cause obesity, and they were referred to in several publications. And there are genes related with both mono as well as polygenic obesity, but there can be other factors playing a role here. Thus, multifactorial cause of obesity. And the second group, this is a sum up of what it looks like, and that's more legible. Let me just consult my notes. We identified 26 variants in 28 people in 16 genes. So some variants are the same, but heterogeneity is very visible here, also in this slide. Group with incorrect cholesterol level, and two tables here, and that's a different situation because the first table shows you gene variants which are pathogenic, and for this group of 8 children we've identified the reason behind obesity. We know it's caused by genes. And the second table are genes related to hypercholesterolemia, but they are VUS, so we can't say clearly that they are responsible or not responsible for obesity in the investigated group. And at the bottom you can see a sum up diagram. We've identified 12 variants in 7 genes in 12 children. So less genes, repeated variants, and variants that are causative and that are responsible for the condition observed in the studied children. And that's a sum up for 275 persons with incorrect BMI. We've identified 26 variants, VUS variants, and 486 with incorrect cholesterol level. We have 12 variants, but 8 variants explain the cause of incorrect level. And one more interesting thing that we are going to keep investigating, because we will carry out future analysis. In the group of children with correct parameters, we have 4 pathogenic variants known and described. Children have correct values of all parameters that were studied. Thank you very much for your attention. Yes, applause, and this is not just applause for Madam Doctor and for the previous speaker, but for everybody engaged in the studies, people who collected data and processed it, analyzed it, and made the presentation. And now, Madam Beata. We will move on to the second debate in a moment, but Professor Jolanta Skup-Cegielska recorded her presentation, and she's going to... Yes, hello, ladies and gentlemen. I regret I can't be with you personally, but I'm happy to share my thoughts from the metabolic perspective on the question posed in the title of this debate, namely, can biochemistry and genetics help in designing effective therapeutic measures? My answer is yes. Well, first and foremost, in congenital metabolic disorders, laboratory test results correlated with identified molecular variants allow for a precise diagnosis. which in turn facilitates the design of an effective treatment. The report discussed today concerns, among other things, hyperlipidemia, including familial hypercholesterolemia in children in Poland. And in May this year, regulation of the Minister of Health introduced screening for hypercholesterolemia and familial hypercholesterolemia as part of health checkup of 6-year-olds. This screening begins with lab tests of lipid metabolism, focusing on LDL cholesterol, and elevated levels of this fraction require the child to be referred to primary health care specialist where further standard diagnostics can be performed. However, if LDL level is exceeded 130 milligrams per deciliter in 2 tests performed 4 weeks apart, the child should be referred to a specialist clinic, preferably a lipid endocrinology, diabetes, or metabolic clinic for children. It is recommended that the parent bring the child with their 2 test results as well as lipid profiles of both parents. The clinic conducts differential diagnosis of hypercholesterolemia, which includes collecting family history of adverse cardiovascular events and ruling out secondary causes of hypercholesterolemia, of which there are many. As you know, these include, for example, hypothyroidism, diabetes, nephrotic syndrome, celiac disease, as well as anorexia, porphyria, Cushing syndrome, and long-term use of certain medications. At the same time, a doctor from specialist clinic orders an analysis of genes associated with occurrence of hypercholesterolemia, and this should allow genetic basis of hypercholesterolemia to be identified and ultimately lead to a diagnosis of either isolated monogenic familial hypercholesterolemia or, more commonly, multifactorial hypercholesterolemia, which is the result of cumulative effect of many different molecular variants. In the study group presented in the report, total cholesterol higher than 170 mg per deciliter was detected in nearly 46% of children, but no statistically significant differences in the levels of this parameter were found between groups according to BMI categories. Similarly, there were no statistically significant differences in elevated LDL cholesterol levels between groups according to BMI category, where elevated level is from 110 milligrams per deciliter of LDL fractions was detected in over 17% of children. These results are consistent with previous observations that children with genetically determined hypercholesterolemia are generally not overweight or obese. The situation is different in the case of hyper-triglyceridemia, which often is accompanied by a higher BMI. And in the studied group, 35% of children had triglyceride levels above norm, but in overweight and obese children, the percentage was more than 45%. And there was a statistically significant difference in triglyceride level in groups with overweight and obesity and non-overweight, non-obese groups. In summary, the results contained in the report are interesting and suggest a need to perform biochemical and genetic tests in children, which, in the absence of clinical symptoms of familial hypercholesterolemia in children, are the main diagnostic tools in this age group. However, interpreting the results obtained is not always easy. Thank you for your attention. Thank you very much. We can lift the screen, and now we will have a discussion whether biochemistry and genes can help us prepare preventive measures that will be effective. Professor Piotr Socha, Dr. habilitated Professor Monika Goss, Dr. Krzysztof Chlebus, representative of the Minister of Health, Kuba Sękowski, and Daniel Ślisz, Polish Association of Lifestyle Medicine. representative of the ministry has no problem participating in more than one debate. So thank you very much indeed. And I would like to ask you which results surprised you the most? Two mics you can share. Well, congratulations, because it doesn't often happen that epidemiology studies do blood work. It's a unique study, and definitely everybody will benefit. Usually we have our own patient cohorts, and we have a targeted medical problem, and the studies and the blood work is very detailed. But I am impressed by the broad perspective of the study and complications of obesity. Obesity is a disease. It's a disease, and disease is characterized by numerous deviations, and we talked about them. So you cannot only look at anthropometric parameters, but also at complications. And then there is such a term of metabolic syndrome, which is used in children from 10 years of age. In younger children, we don't even have a good definition of metabolic syndrome. So risk factors that determine cardiovascular risk at a later stage, also renal risk. But I'm a hepatologist, gastrologist, who is interested in fatty liver, and we have a new term, MAST, metabolic fatty liver disease, in the course of obesity. And Professor Fiałkowska, I already talked about it. One thing was missing, ALATs and parameters related to fatty liver, because this is the part of complications of obesity that we don't often talk about. We focus on cardiovascular risk. We seldom talk about liver. And there are concrete criteria. And in ESPGHAN, we are working on a new position to diagnose and treat MAST. And ALATs will be an important screening parameter towards MAST, because sometimes it's easier to test a lab parameter rather than make under detailed tests. So some tests are not precise enough. So lab tests are very important, and they are included in screening for hypercholesterolemia and obesity complications. So very happy about that. So a very interesting gene review. There are certain genes which are related to metabolic complications. Genes that cause obesity and monogenic diseases are very rare, but there is such a gene, PILA3, which is a risk factor for fatty liver and other metabolic disorders. It shows you the risks related to obesity. And carriers of that gene who develop fatty liver, they also can lose weight easier. So if you have this risk factor, you might be obese, but it's easier for them to lose weight. Yes, it does cheer one up. And now, Professor Chlebus, Dr. Chlebus, what surprised you in these results? Well, I think the most surprising parameter was the rate of young patients with elevated LDL. I deal with adult patients on a day-to-day basis, and I know what prevalence is in adult population. But it's surprising that children are close to these values. It would seem that adults have worked on it really hard to have that level. Yes, it's quite alarming, I think, because if among adults 60% of the population have lipid disorders, elevated LDL, these parameters, almost 50% for children, are really terrifying. This means that in the future, in the nearest years, we won't be able to improve the situation. And I think that what's important, and it hasn't been yet highlighted strong enough, but I'd like to do that now. And I'd like to thank Professor Fiałkowska, because she and her collaborators diagnosed patients with familial hypercholesterolemia. And this is a big thing, because it's the first time that we've had a sample confirming the results of studies for adults that we extrapolate to children. So, showing this, that we were able to diagnose 8 children, very special children.
And I don't know whether you realize what type of conditions we're talking about. It's patients that very shortly will generate different cardiovascular complications. So their average, they are not homozygotic, so they are dealt with by pediatricians, but these can be very dramatic. We are talking about deaths, about heart infarctions, about at the age of over 10. And heterozygotes also lead to some cardiovascular problems. So that group of 8 children have very serious conditions. We can expect that half of them at the age of 50 will be already dead if they are not treated. So I think that reflects very well the condition of the Polish population. We know that we have some 160, 80 or even 90,000 people. And remember, it's not a rare disease, even though some people say that. Well, that depends on how you define a rare disease, but it's a population of people that are not aware that they have that problem and that they can develop very serious complications. So it's not only about triglycerides, but also other tests that should reveal those abnormalities. And by the way, LDL is these days not such a great sign pointing to obesity. Elevated triglycerides, however, show some metabolic abnormalities. So your child, in such a case, is not only obese, but also is very much bearing a high heart risk. So if you deal with patients, and me dealing with adult patients, that struck me really after reading the details. Hello, ladies and gentlemen. Thank you very much for inviting me to that panel. Being a geneticist, I must say that I was surprised myself by those biochemistry lab tests. I don't want to repeat what already has been said, but yes, I was surprised. Looking at the genetic aspects of that study, these results should not be that surprising. If you look at the literature, some 5 to 15% of cases of obesity is caused by the monogenic factors, where you have just one mutation in one gene. And we confirmed that some 10% of children with elevated BMI or TC, in those groups we identify some variants that could lead to those conditions. Let me now refer to those that don't have a full clinical significance, because you have to differentiate here clinically. On the one hand, you have some children that have to be reviewed by a clinicist to compare the current situation with the genes. But if you talk about hypercholesterolemia, I think it's quite clear that you have a pathogenic variant that led to that elevated level of cholesterol. The number of these patients in 2 groups is very low. It's not even 10%, which means that in most cases both obesity and hypercholesterolemia is not only driven by genetic factors, but rather by the environment. So here we need some interventions limiting the factors that drive obesity or that affect their blood results. Such interventions can be helpful to counteract hypercholesterolemia, overweight, or other problems. Thank you. Yes, indeed. This is what struck me as well. Meaning genes don't allow us to explain all of the cases, but just some of them. Now to you, Mr. Sankowski, how should we interpret that we have a growing number of children with overweight, but genes are not that important? So let me say that if you have a representative sample, to carry out such a study, it's a great step, also internationally. I'm just so proud of our Polish study, because indeed that's something that you can brag about all over the world. It's not about just telling a story about some self-reported data by patients. Such studies don't have a huge impact. Now, focusing on the outcomes. Interpreting the outcomes will be very much dependent on the type of profession that the interpreter has. So I see some continuity here looking at the previous panel. Namely, parents that bring their child to a GP with a problem. Maybe it's visible because the child is overweight or obese, or maybe something is wrong in their blood test. The parents can say, well, you know, it's a family thing. We are all a bit overweight. It's just that in very few cases, it's the actual inheritance. It's rather that you inherit not your genetic makeup, but rather some habits, some behaviors. Still, I like to see half glass empty. That is, you can't use genes to explain things. You can't just say, well, that's the way I am, that's the way my children are. So from the viewpoint of how we talk to parents, I think it's important. We now can clarify, you can't use that justification. However, in cases where we do have those genes, we can make prevention more individual, because then we know the individual conditions of patients. And we won't just tell them to do what we say to other patients, because we will know that this patient is a member of a risk group and is prone to have cardiovascular events in the age of 40. This is what you said before, right? That those children really need specialized care. And in each cohort, there was a group of children with such genes. As a result, we may have now better supervision over such patients. And I think that would also be a huge benefit from the viewpoint of the social public health. So you're talking about individual pathways for individual patients. For the group, for that group of patients, we should have an individual path. Supervision maybe is the wrong word, but we need some targeted interventions that have to be intensified because the risk is much higher. Right, let me now move on to you, Professor. Talking about the liver. So what liver does an average 80-year-old have? Because the fatty liver syndrome is now visible also in children. I can't tell you exact epidemiological details, but there was a Chimeras study carried out in the US, just like COSI. They looked at population between 12 and 18, if I understood correctly, and they looked, among others, at labs. And it turned out that, for example, ALAT was about 55. But if you exclude obese patients, then it goes down to 22. So it's really hard these days to set clear norms for the population, because in patients with obesity, all of the parameters are a bit elevated, and ALAT is really the parameter that reflects fatty tissue. I can tell you some details about the work that is yet to be published, but we will say that 30 should be the right range. So ALAT is the best parameter to image the liver function. Now, ultrasonography or fibroscanning This gives us some more or less advanced options to image the liver, but for a GP that carries out simple screening, probably testing ALAT from the blood would be the best option. Why is it important? Well, it's really the case that a patient with fatty liver requires a transplant when he or she is a child. But we do have such cases in Poland, and especially those children that had one type of cranial surgery. And in the US, the patient's craniopharyngioma, that was the surgery that led to such necessity to transplant liver, also in children. So liver disease is a very important one that is also part of potential obesity complications. That's why I always try to focus more attention on the liver, because cardiovascular risk is something that we know very well. There are already some screenings in place, but we frequently forget about the liver. So I would like to remind you that liver should also be the center of our attention. Thank you. So what does the treatment of children look like? Those that have a detected gene behind their obesity, and what is the care of children that don't have the gene mutation and still have an elevated hypercholesterolemia? So before I answer that, let me just quickly comment on what Professor said. When I talk to my adult patients that have cardiovascular complications, it seems to me that the liver is very high on the priority list of patients. After 3 myocardial infarctions, bypasses, and so on and so forth, patients are worried about their liver. They ask actively, what about my liver? How am I doing with respect to the liver? So it seems that there is awareness of that problem. Coming back to your question, I would put it this way. Indeed, young patients that have very high LDL and have confirmed genetic mutation, those patients should be actively treated by with pharmacotherapy. We deal with the whole families in such cases, not just with just the child. So in that cascade model, we diagnose children, but in our diagnostics right now, in our register, we have about 650 children that are actively treated with statins. So the youngest patient, I think, is 6 years old. So I'm talking here about lipid lowering treatment. We also have some monoclonal antibodies as an offer. They are available starting from the age 9 or 10. So in fact, we have a huge palette of treatment options right now to lower cholesterol levels. However, that gene mutation normally requires putting them on such treatment. And please remember that all of us produce such lesions, some plaque, for example, in arteries, for the whole life. However, in these children, that process of plaque formation starts very early on. And we have some scientific evidence now that shows that we should put these patients on such aggressive treatment as soon as possible. And I created a model some years ago. It's still being used, not only in institutions officially, but we've been able to diagnose several thousand patients with that gene mutation. So we have a dedicated pathway for such patients. And I talked to Professor Fiałkowska. I hope we will be able to persuade also parents, because those parents, if the children have the mutation, then one of the parents definitely also has that mutation in question. So we will persuade them to also be treated. without any ado. What about the other children, those that don't have the gene mutation and no extreme LDL levels? However, these two groups sometimes overlap. If you have a group without the mutation with high LDLs, well, in such a case, you have the so-called mixed lipid condition or disturbances. That means that such patients have a multigenic nature of that condition. So such children respond much better than adults. Still, we should introduce such therapy. That's not really the case for children, though. It's rather interventions to change their lifestyle, to lower their LDL. So it's a different risk control methodology, and I think this refers very well to potential problems with kidneys and liver. So it's about hypertension, it's about obesity and overweight, and we really need to join our forces to address these three, because such therapy can be very efficient in children. So just elevated LDL without the gene mutation, so it's polygenic then, is a great indication to change a lifestyle. Question remains whether that will be efficient, how parents will react, and whether long-term parents can change the lifestyle of their children if, and we know that, they are not able to change their own lifestyles. So also, such children should be monitored and they should be educated. However, as I said, it also refers to parents, not just to children. Otherwise, we will never change these rates. Consequently, children with family hypercholesterolemia, when they turn 18, they immediately become our patients. And then we need to treat them. So hopefully, those patients without gene mutation will be able to change their lifestyle choices. Right, let me ask you one more thing. You said that these patients will come back to you once they turn 18. However, who should take care of them if they are still pediatric patients? After all, they have not developed the disease yet. So are pediatricians prepared to provide help to such children? Well, that's the same problem that we have with adults. Remember, there are two groups. Those that have the genetic mutation. For those patients, even primary prevention is very clear. We already monitor them, we address them, we treat them with aggressive treatment. Whereas the other group are, the same applies to pediatric patients, and some new sites have emerged, like the one in Gdańsk, where we also initiate such conversations with other clinics. For example, now we have contacts with pediatric clinics that declared willingness to take patients. So again, it's a non-systemic initiative because unfortunately, and I'm speaking on my own behalf, we can't engage in effective conversation with the Ministry of Health. However, for some time now, and this is not, don't take it personally, please, it's just that I used to try to push certain things through and it didn't work out. So we still don't have systemic solutions. When you talk about healthy individuals, both pediatric and adult patients, well, indeed, it's a problem to take care of them permanently. In the case of adults, there are some programs such as 40+, and improving the system finally allows us to not only do the labs, but also consult these labs and come up with some solutions. However, a lot depends on individual patients. 3 sites in Poland initiated a program in Poland called Cordion. It was dedicated to primary prevention with patients with such conditions. But these are initiatives, they are short-term. And our problem is especially visible in children. Who should take care of healthy children that don't have a genetic mutation, but that have cardiovascular risks and other risks, in fact? So there is a gap here that should be filled. But I agree with one of the statements before. That's probably not an area for doctors, but rather for educators and for many other professions that could provide them with some systemic support.
Director, should we act systemically? Does the minister know the problem? And should we act systemically? Because it applies to a lot of children. I don't want to answer out of respect for you as regards treatment and placing certain therapies or regimens because public health is far from doing that. But unless we deal with those patients, it will have a big impact on public health. Well, it does have impact on the health of the whole population, but the thing we focus on, and I try to express it in everything I say, and that's at the very beginning of the natural course of the disease. And so I will only say that once we diagnose a problem, we simply cannot say that it's a monogenic problem. So your health depends on the genes you inherited. We see other things, so we can implement what the professors talked about, and I fully respect what the professionals are saying. We also talked about other things. Healthcare system is the most expensive method of intervening. It's the best, but it's also the most expensive. So working time of a lab, a doctor, a nurse, a hospital, or outpatient special care. These are the most expensive services that a society is sponsoring. I wanted to say the state is sponsoring, but actually it's a society. So that is why we have to say we need to look for methods of intervention using the simplest and the most available resources. So here there's a role for preventive care and health educators. But it's also about cooperation with other sectors, like early intervention. So health is perceived as the domain of the Minister of Health. And this perspective will not be seen by a social worker, which visits a family which has low socioeconomic status. Probably there might be other problems, and it won't be seen by the teacher in school. Also, a coach in a sport club will not see this problem. So health is so serious that people say we should leave it in the hands of the health system. People keep waiting, and finally, when they are in this advanced condition, they get to into the health system. But it's also about the tools. I talked about the temple and burning a candle, burning fire, and these are the tools that could be used somewhere else. So, it's good that the medical facility is taking interventions, but the intervention should be continued by itself, like in education, with a health sector only monitoring. We, as health sector, we are not necessary. We don't have to intervene in schools where children are raised. This is not the role of healthcare. Coming back to you, Madam Professor, because since we know what genes are responsible, and in the case of some patients, we can implement individual patient pathways which are preventive. So if we know we can prevent certain events, including genetic tests to assess risk in broader population. Is it necessary in the years to come? Is it real? So from my point of view, as geneticist, failing to do such test in a patient who has a clinical condition, and this test could be useful, it means not using of the potential of those tests. Personally, I think that whenever it's possible, genetic tests should be carried out to confirm clinical diagnosis. And in the future, it will translate into personalization of treatment, just like we have in the case of ALS, where we identify patients through screening. Statistics have been on the rise. So yes, in the case of ALS, and all other diseases screened for in this program, it's possible to offer individualized care. And genetic tests are an element of screening, because we are not just doing biochemistry tests, but also we confirm diagnosis by genetic tests. The problem in the case of obesity and disorders, lipid disorders, is that a vast majority of cases are related to many genes. We define these diseases as multifactorial diseases, ones where there is a genetic component, but to a large extent it's modified by environmental factors. So in populational studies on obesity, associative studies carried out over different populations, 500 genes were identified that can have impact on obesity. So this genetic testing becomes complicated. And since these are loci, which are specific for population, so in one population, a given locus is connected with obesity, and in another population not. So even earlier, we should carry out big studies for the Polish population, because they are not variants in the genes that we identified in our studied group. We identified potentially pathogenic variants. These could be actually totally different genes on the list that were actually not listed. So for me, the problem is that these studies are complicated. They require broad tests on big population in Poland to connect gene loci with specific diseases in the Polish population. Coming back to screening tests, well, I was preparing for this question, and right now in the world we have different screening tests using next generation sequencing, which allows us for single time analysis of different genes in newborns. And I asked myself the question, looking at those programs, which of them have tests for hypercholesterolemia or obesity? I checked gene list, and it turns out it's only in the Australian population. It's one of the populations where the tests are made for hypercholesterolemia and obesity. But what I wanted to highlight is that in Europe, we focus very much on a justification of screening, relevance of screening. Well, in fact, it has to be a disease for which it's possible to start early therapeutic intervention, whose symptoms occur before 5 years of age. And these are debatable things. So obesity, hypercholesterolemia are these diseases for which early therapeutic intervention before 5 years of age is possible at all. And such rules are implemented by the consortium that deals with sequencing of genome in screening among newborns. So if you look at European studies, in those European programs, they do not analyze mutation in different genes that the speaker mentioned, as the genes whose mutation could be responsible for a disease for which we have early intervention, and where the symptoms occur before 5 years of age. As geneticist, of course, I think it would be nice for each newborn to have their genome tested. But now, my postulate is to use our potential with regard to diagnostic genetic testing, where we have a patient with changed parameters, changed symptoms and clinical symptoms, where genetic testing could be performed. But thanks to that, we also learn how potentially we could implement these tests as screening. So genetic testing is very much needed, but because of the polygenic nature of obesity, lipid disorders, well, I would be cautious implementing such associative tests for the whole population. Thank you very much, Doctor. Yes, I have a comment. Now, as regards the efficacy, we do have global literature confirming that cost effectiveness of such measures involving genetic diagnostics is the highest when we have results in children. When we do these tests at a later age, looking at cardiovascular complications, we are much less efficient, and it is the biggest sense for these tests. But we are talking about targeted tests. Like you said, madam, because as regards screening, there is no need or possibility, financial possibility. Even the richest countries in the world will not do screening for genetic testing. The cost will be huge. So, to answer your question whether these tests are needed, just to give you an example of what we have in adult diagnostics, the discussion about the need to diagnose familial hypercholesterolemia has been implemented in Poland for the last decade. When I was founding our center, I was talking about the need of genetic testing, and without accepting any other solution. But nevertheless, there were discussions about it, and today let me quote our data that in fact among patients who were diagnosed with a certain genetic mutation, 75%, actually 76%, have less than 8% on a VLCN scale. So from a clinical point of view, they have a highly likelihood of diagnosis, but there is no confirmation. So without genetics, for 75% of patients, we won't have a certain diagnosis, which is key for further treatment, not just to use biological drugs and effective treatment, but also what is important for genetic diagnostics of family members, cascade diagnostics. So we won't go further, and this is the most cost-effective thing, cascade diagnostics for children of these patients. So in my opinion, this is such a huge amount of data documenting the need to carry out genetic testing in specific situation that it's only what is left for us is to use them. This discussion is actually finite. And yes, we can see that biochemistry and chemical testing opens new possibilities in diagnostics, but they require integration with clinical practice and public health strategy. So thank you very much, ladies and gentlemen, for participating in the debate. And now we're moving to the next part. Thank you very much, ladies and gentlemen. A short break of 10 minutes for coffee. And we will meet in 10 minutes. Ladies and gentlemen, please take your seats. I know the cake is delicious, the coffee as well. I do promise after the end of the presentations and our debate, we will have time to eat some more and drink some more. Please take your seats because we are starting the third and the last part of our conference. We've already held 2 sessions. The third one is effective prevention in children in early school age. How do you ask about physical activity in populational studies? So, one more time, please take your seats and we can get started.
Drodzy Państwo, zanim przejdziemy do panelu dyskusyjnego, mamy połączenie.
We have a connection and 3 presentations. I will ask Dr. Anna Dzielska from the Institute of Mother and Child, but before that we are connecting with Helena Krizan, Croatian Institute of Public Health.
Voice.
Hello, everybody. It's very nice to be with you today. I would just like to present to you today the results of collaborative work on improving physical activity measurement in the COSI study. As I understand, previously today you have mentioned the COSI study several times and its importance for childhood obesity surveillance in the European region. So continuing with that, let me just start my presentation. I hope you can see the slides. Oh, okay, great. So, as I said, the point of this study was to validate a single item question that would allow us to estimate how many children meet the WHO guidelines for children on moderate to vigorous physical activity. And we decided to validate this item by using accelerometry. The purpose of this validation exercise was to possibly come up with a question that we could include in a future version of the COSI family form. Since we were doing the study anyways, we decided to check for a few other things at the same time. So one of those was to examine the validity of a single item question on the amount of time the children spent being sedentary, i.e. sitting or lying down with the exception of sleeping, regardless of the kind of activities the child would be doing while sedentary. We validated this question through accelerometry as well. And then since the children in the study would be wearing accelerometers while sleeping, we decided to investigate the level of agreement between the measurement of children's sleeping time based on one parent's report through the COSI family form and, of course, the accelerometer-based measurement. So the new questions we devised for moderate to vigorous physical activity looked like this. So we explained to parents what physical activity is. And in one version of the question, we asked them just a very, very simple question. As a parent, do you think that your child does at least an average of 60 minutes per day of physical activity? Yes or no? So as you can see, this question is highly compliant with the new updated WHO guideline on moderate to vigorous physical activity. The second question is a lot more complicated version of the same question, where we ask the parents for each of the past 7 days how many minutes their child spent doing physical activity. So the exact number of minutes for each day in the past 7 days. When it comes to sedentary behavior, we devised a similar question to the one on moderate to vigorous physical activity, which is by day, we ask the parents to list the exact amount of hours they think that their child spent sedentary. And then on sleep, we used the standard COSI questions, just slightly amended. And the amendment was in regards to we explicitly specified that bedtime refers to the point when the child turns the lights out to go to sleep and not just goes to bed as it was previously in the COSI family form. And we separated bedtime for weekends and school days and wake up time as well. So we did the field study in the academic school year of 2023-2024. The study was conducted in 9 schools. The original plan was to include 8 schools, but in order to reach the planned sample size, we had to include 1 additional school. And after 9 schools, we had accelerometry data on 226 children. The schools were in all 4 regions of Croatia, so we had geographical representation, and we also included both main and peripheral branch schools. If we look at the sample, we started with 226 children with accelerometry data files. We had to exclude 13 children from the sample due to corrupted data files or missing some survey data or raw accelerometry data files. And we ended up with 213 children. As you can see, we had approximately the same amount of boys and girls in the sample, and the mean age was 8.9 years. So let's get to the results. As you can see here in this very brief table about the comparability of parent-reported and device-measured moderate to vigorous physical activity, you can see that in terms of agreement, the single-item measure demonstrated slightly higher accuracy, so around 54%, and a relatively higher
A także trochę większą czułość, czyli 89%.
the version of the question where the parents had to do a 7-day report in moderate to vigorous physical activity. So we are assessing children's compliance with the moderate to vigorous physical activity WHO guidelines. And as you can see, both of these measures had very low specificity, so 17% and 9%, which indicates that they have a limited ability to accurately identify children who did not meet the guidelines. And you can also see the small and negative kappa values for both parent-reported measures, which further highlights this very low agreement between the parent-reported and device-based measures. So what do we do with this data? Well, in conclusion, you can see that there are significant discrepancies in the guideline compliance rates between the parent-reported and the device-based measures. The single-item parent report measure has slightly better accuracy and sensitivity compared to the 7-day report, but they both demonstrate very low specificity and poor agreement with the device-based measures. So what now? in context where the device-based measures would be not feasible to use, for example, large-scale population surveillance studies such as COSI, we still would need to find a way to measure physical activity through parental reports. It seems that the single item measure may be a bit more ideal to use because it has relatively higher sensitivity compared to the other method, the 7-day report. And it is simpler for the parents to fill out. So we had a lot less missing data and incompleteness in this item than in the 7-day parent report item. But I conclude they are still not good, reliable measures of physical activity. And I do hope that in the time that comes, we will find a way that will make it feasible to use device-based measures for large-scale population surveillance. But so far, we seem to have to still keep relying on these parent-reported measures, even though, as I said, their validity is very low. When it comes to sedentary time, you can see that on average, the parent-reported measure underestimated sedentary time by approximately 4 hours. So parent-reported sedentary time was 5.3 hours, while the device measure had a mean of 9.2 hours. And you can also see that the absolute mean bias reached up to 4.2 hours with very wide limits of agreement. If we look at the days, so across all days, we can see that there was no perfect agreement observed between the parent-reported and the device measures for the estimated sedentary time. Half of the days had discrepancies within 4 hours, but you can see that almost 24% of days had discrepancies exceeding 6 hours. So sometimes the parents were very off in regards to how much their children are sitting throughout the day. So what we can conclude is that parent-reported measure underestimated children's daily sedentary time by approximately 40% compared to the device-based measures. And this, I think, reinforces the limitations of relying on parent-reported data to estimate children's sedentary time. And this is likely due to parents' lack of accurate knowledge about their children's activity patterns, especially during school hours when children are away for extended periods of time. So parents probably don't have a real idea of how much exactly their children spend sitting down during school hours. As I said, we also investigated sleep. In sleep, we found that the parent-reported method systematically overestimated the sleep period length compared to the device-based method. And you can also see in these plots that there was evidence of a negative trend in bias, suggesting that the difference between methods decreased as the sleep period length increased if we use the device-based measure as the reference method. So once again, our results show substantial differences between the survey and device-based methods in measuring sleep period length, which further reinforces the lack of comparability between the two measures, probably in this case due to some inherent differences in the constructs being measured. The parental report probably still measures the time when the child goes to bed and gets out of bed versus when they actually fall asleep and wake up. So I think this just emphasizes the need that we always need to consider the context of each method when we are interpreting sleep data in these large-scale population surveys. So, in brief, this were the results of this little study. The Polish team will present their own results, and we were very happy that we could replicate this study in 2 countries so that we can be completely sure if the findings are the same or if they're culturally specific. And please stay tuned for the Polish results as well. And even though I just spent a couple of minutes now going through this study, it took a lot of work to make the study happen. So I would specifically like to thank my whole team, the school staff, the students and their parents, and of course our collaborators in WHO Europe and even in Australia who helped us devise this study and make it happen. Thank you.
To you. Thank you for your participation, for your presentation, for your cooperation. Helena Kriżan z Chorwackiego Instytutu Zdrowia Publicznego. Uśmiechała się pani doktor.
And you smiled many times, madam, while you were listening to the Croatian study results. So why don't you now present the comparable study that was conducted in Poland? Thank you very much, and I'm very grateful to Helena for presenting the Croatian part. She was very detailed. Well, my presentation will be a bit more general. I'm going to spare some methodological intricacies to you, but indeed, the outcomes that we have are very close to those that our colleagues from Croatia had. I will speak here during 2 presentations. The first one will be on validation, where we looked at the evaluation of physical activity and whether it reflects properly the reality, if at all. And the second presentation will be the outcomes of our long-term efforts and motivations to create something which could prevent overweight and obesity. That's my next presentation. So let me start with validation. That study was co-conducted with WHO and the colleagues from Croatia, and it was based on our joint protocol. We started the whole exercise with a pilot project in September 2024. And then the studies were rolled out until February 2025. And that was a very complex process that required participation of hundreds of people, mainly school nurses, that made sure that children are put on scales and measured. But it also applies to educators and teachers, because they ensured that the 8-year-olds wore accelerometers. That was not that easy. And they also made sure that parents are properly informed. Also, I'd like to give credit to all of my colleagues, because we had to organize many site visits to different schools where we did the studies in the field. So this is our common contribution. Thank you. So our plans are as follows. We wanted to look at 21 schools to have the sample of about 500 children at the age of 8. We involved the school teacher, school nurse, but also researchers. Well, the other reality turned to be a bit different. It was very difficult to recruit children to a program where they had to carry with them a device on their wrist for 8 days and only take it off in special circumstances. So in the end, we carried out the study in 6 voivodeships, in 21 schools. And all in all, we did test about 500 children, reflecting the sex parity, mainly 8-year-olds, second graders. Half of them were inhabitants of cities. The data that I'm going to present to you will be just a tiny detail of what we gathered. It will be based on the results from children that wore accelerometers for at least 7 and up to 8 days to have a full picture of their 24 hours activity in the studied period. And here are the accelerometers. They are a bit bulky, as you can see. However, in some other studies, there were even bulkier devices that children had to carry on their tummy. So, to be well prepared, we took part in many trainings, and here the credit goes to WHO Regional Office for Europe. And also we were able to organize a visit by experts from Australia who taught us how to analyze the data later on. That was a crucial element of that study. Also, nurses, parents, teachers, again, received trainings that we conducted. Sometimes we had to work overtime to provide these trainings, but the point was to create conditions to teachers, children, and nurses so that all of them know what the purpose of the study was. We prepared vast documentation. Parents were asked to fill in questionnaires and answer some questions that were presented by Helena before, so I'm not going to repeat those questions. It was about sedentary behavior, sleep, and physical activity. Also, they were obliged to carry out a log. Every day, they had to enter any events related to accelerometer that should be taken note of when analyzing the data. Also, they received special manual on how to use the device, whereas school nurses would conduct anthropometric measurements so that we have reliable data. Now, what is it that we can establish about physical activity of the children in the study? Helena told you a lot, and our results are very similar. Indeed, parents do overestimate the time of physical activity, active to moderate. In the opinion of parents, is 91 minutes per day, whereas according to the accelerometer, it's 57 minutes. This pictures those discrepancies. The higher activity of the child, the more different the results between the accelerometer and the parent. I came up with some cut-off points for sedentary behavior and physical activity so that you can realize the scale of the issue that we are facing here. It turns out that some 80% of parents claim that their children are active to a sufficient extent, that they have like 60 minutes per day. However, accelerometer indicates that it's only 40 minutes. Remember, we are talking about 8-year-olds whose natural need is to move, seemingly. You might expect that these numbers would be much, much higher. And I'm talking here about moderate to high activity. So it's not sports, but it's rather a more intense activity. Parents seem not to see that difference. Helena mentioned that. Maybe the reason is that for many hours during the day, they don't see their child because the child is at school. And I'd like to share with you one more result that depicts the lack of activity. So that's the sedentary activity, apart from sleeping. We asked parents, we did the measurements, and identically as Croatians, most parents underestimate that activity. They believe it's 5 hours, but accelerometer results say it's 9 hours. And summary, I'm not showing you the data that Professor Fiałkowska showed you before, so let me just emphasize that when we came up with those cut-off points, when we looked at how many children in fact sleep 9 hours, it turned out that there was just 1% that did sleep for 9 hours. So to sum up, in our study, we were able to demonstrate that children are less active than we like to think. So only a couple of percent of the children fit the standard. Also, children sit or lie much more than we think, on average over 9 hours a day. At the same time, we know very well that using accelerometers is not possible in all circumstances due to different reasons, especially if you talk about huge populations. That's why we need to make an effort to keep improving the tools that we have to carry out population-based studies so that we can identify much better those individuals that are problematic because they are not active enough or they sit too much. And that's a photo from the field so that you realize what it all looked like. I'd like to thank once again all the teachers, nurses, and my team for their dedication to carry out this study. And to our participants, after all, they had that difficult mission to carry with them those burdensome accelerometers. Thank you very much. So now I'm going to pass to my second presentation, where I will present to you initial results of our prevention program that we designed on the face of our observations of early school children in order to react to some data that we saw. So first let me tell you why, and then let me tell you how, and to what outcomes it led. So this is what Professor Fiałkowska already shared with you. Let me just briefly reiterate. So what we see is that overweight and obesity grow with age in early school period. That was the first reason behind the program we designed. Also, we see that these percentage rates are very, very high and they don't change in time. There was a big peak during COVID times. After COVID, it went down a little bit, but we still are at the level of 2018.
No i właśnie, stwierdziliśmy, że
We also decided that we wanted to develop a tool that would be easy to use and that would limit the risk of obesity in early school children. So at the age where the problem is huge. We wanted to improve children's health behaviors by familiarizing children and parents with recommendations for a healthy lifestyle. We wanted to teach them how to implement the recommendations. We decided to design a program that would be at the lowest prevention level, so a primary prevention or universal prevention, depending on the terminology you use. So theoretical assumptions tell us that development of behaviors is shaped and developed in a bigger system in which other systems are located, and interactions between them have impact on the outcome. And this is Professor Brenner's theory of ecological systems. And we decided that we wanted to use it in the family and at school. And we know from literature that children learn by observing others. So our assumptions were based on the theory of social learning. So our participants were children in class 1 through 3, where we observed those phenomena of obesity and overweight, school nurses, headmasters, school teachers, and parents. So school was supposed to be the system where we have impact on, but also family, which cooperated with us strictly during the implementation. And these components were implemented. We developed a textbook for teachers and school nurses with detailed lesson scenarios about 5 topics that, according to research, seem to be factors that could contribute to obesity and overweight. So we were talking about nutrition, about movement, about how to spend free time so that it's not sedentary time. We were talking about the quality and superpowers, and so about individual resources, and we were trying to reinforce those individual resources of children so that their ability to engage in positive behavior is increased. We had a brochure for parents with recommendations and tasks to be performed with parents after each class at school. We also analyzed the initial situation and reflection on the strategy for supporting healthy behaviors among pupils in the area of physical activity and proper nutrition. And that's the scheme of our intervention. We are of the opinion, of course, that if we want to implement a preventive program, it should be efficient. So we wanted to investigate the efficiency of our measures, and we did it in the form of randomized controlled trials in clusters. For measurement points, we were asking about the starting point before intervention. We were asking in the course of intervention, right after it ended, and 6 months after the end of the intervention. The intervention was only implemented in the experimental group, and in the control group we were only doing tests. And these are our results. When it comes to the main outcomes and variables, and there are a lot of variables: behaviors, impact of the environment, different indicators related to health, but these are the most important because they happened within the framework of the main variable, outcome variable, namely obesity and overweight and change of BMI Z score median. In the control group, we had negative changes when it comes to BMI Z score. So there was an increase in BMI Z score, while in the intervention group, there was no such change. So it turns out our intervention could have brought the expected outcome in the form of limited risk of obesity in the intervention group. The same applies to the rate of children with obesity and overweight, where we can see a significant change in the control group, negative change, and in the intervention group there was no change. And elevated WHDR, that's belly obesity indicator, abdominal obesity indicator, which after 6 months increased in the control group, and the rate of children with elevated WHDR decreased in the intervention group. So 3 successes in the main variable, outcome variable. So to sum up, we know that obesity and overweight have been growing. They grow with age, and we know the situation hasn't changed for years. In early childhood, we can already observe overweight and obesity. And we also know that it's not enough to treat, it's not enough to address the group at risk. So the group where there already is obesity and overweight. I'm talking here about secondary and tertiary prevention, but it's also important to focus on children where there's no problem yet. So universal prevention before the problem occurs. So preventive measures should cover the entire development system, in particular the family and school, the whole system. that impacts the child development, but in particular family and school, because they are closest to that development. The results of our intervention found that a clear, simple, easy to implement solutions can be effective, such as our prevention program. It confirmed its efficacy because it stopped an increase in incorrect body mass in children in intervention group vis-a-vis control group. Thank you very much for your attention. Madam, thank you very much. Thank you. That's a ray of hope in the sea of negative information stemming from all these studies. That's a ray of hope that we would like to follow up on and that we would like to take advantage of. And the last debate of experts: how do you develop a sustainable obesity prevention system in Poland? How do you combine subjective data assessing physical activity in children? So I'd like us to discuss it with the following experts: Beata Małecka-Libera, Senator of the Polish Republic. Sorry, you can't hear the comment without the mic. No senator. We regret that. Dr Michał Brzeziński, professor of the chair and clinic of pediatrics, gastroenterology, allergology, Gdańsk Medical University. Thank you for coming, doctor. Professor Daniel Ślisz, professor said that he only wanted to participate in this panel, so glad to have you with us. Professor Dr. Habilitated Piotr Jankowski, Dean of Public Health School, Medical Center of Postgraduate Education. Welcome, sir. Hanna Nałęcz, Physical Education Academy, and Mateusz Łach, Director at the Department for Planning and Strategy, Ministry of Sports and Tourism. Applause. Well, I can see you smiling, so I hope we will have some positive conclusions about prevention. So, how do you create an effective and sustainable system? Whom should we address it at? The studies say that it's possible if you use simple methods and clear methods. You are able to generate positive outcomes over a short period of time and see the first changes. And in the slide, you said, become a chef. Become a chef. Well, I remember my son once came back from classes at school, and yes, he does want to be a chef at home. Not sure if it's sustainable, but this is an example of one of the changes that can be implemented. And I was wondering what your experience is about nutrition and our knowledge about nutrition. Welcome, ladies and gentlemen, and thank you for your invitation. My 9-year-old Leo, yes, we are in the same league, says that he doesn't understand what the problem is with eating fruit and vegetables, because he eats 2 peppers every day and at least 1 apple, and I still think it's because of the fact that his parents do it. He follows his parents. Let me remind you, 38% eat vegetables. I took the picture of that slide and sent to a WhatsApp group, and I asked parents who's not giving fruit and vegetables to their children, and nobody said they weren't feeding children these products. So, should a child be a chef at home? Yes and no. It's the parent who decides what, and the child decides how much. And I don't think it's a problem of children, but the problem of parents. The parents are not simply ready. They don't know where to take knowledge from, although As two big companies prove on the market, one is more Portugal, the other one is more German, they show that they have very clear information as to why parents do it. It's about the price and availability. So when the price is available, parents buy much more. It's hard to say whether children will eat more, but an attempt to force a young child to eat all vegetables and fruits is failed. If you give something what they don't want, such as sauerkraut, because we eat sauerkraut, forget about it. Kids like elementary diet, so separate carrots, separate tomato, separate cucumber. And if I say let him eat 3-4 vegetables, and that's sufficient for his good functioning, and he doesn't have to eat Brussels sprouts or cooked cauliflowers. And I'm not surprised he doesn't want to eat that. So, bluntly speaking. But should he be a chef? Well, yes, if I had the support of health education, he should become a chef, but it does have negative conditionalities, but that's not for today. So generally speaking, I think that if we want to make sure that kids eat healthy in a sustainable way, they need to get this chance at school. They need to get this information at school. That's point one. Point two, parents should have access to fresh fruit and vegetables. And here, apart from feeding children at school, so availability of fruit and vegetables in school, these two big discounters have a role to play. In recent years, they've done a big revolution in availability of fruit and vegetables by promoting buying fruits and vegetables for extra score and awards. They did more than many ministries. And thing number three, if you look at how to make it sustainable, well, the solution is systemic. So from the self-government perspective, in Gdańsk, when I've been working for 15 years, we have such systemic measures, and indeed everybody, all school chefs in Gdańsk were trained on several occasions on how to prepare healthy food, but this is a consequence of the fact that the city authorities are thinking about it. So it's really hard for local government to do it, because we would have to visit different mayors and tell them this is the right direction, Mr. Mayor, Madam Mayor. No. Fruit and vegetables, why is it there's such a high tax on them? They are so expensive because there is such a high tax. Couldn't we have a zero tax on them, which would significantly reduce the price? Why their availability is limited by different restrictions in schools, that these kids can't easily prepare it in school stores because there are sanitary recommendations about Salmonella or Shigella, but the populational risk is extremely low, and the value for these kids so that they can have a school stores where they develop and prepare meals is really high. So Finland, Scandinavian countries, this is how they function. Because they teach kids practically how to prepare meals. But most of you don't remember. I remember those classes at school where we were learning how to prepare meals. We were learning to cook, to cut, to bake. And this is something I did have at school. It's worth coming back to that. And let's not be afraid of it. I talked to a befriended gelateria, a good gelateria, because a lot of kids eat sugar every day. Why aren't they doing workshops for kids? And they said there are so many sanitary limitations that they would have to have 3 times bigger room in order to let anyone in, to show how it's done and to prepare it from a practical point of view. These are the barriers and limitations that we are implementing, and then we are surprised that the kids do not know where ketchup comes from. They never saw a tomato plantation, how tomatoes are grown. We all remember the smell of tomatoes from a garden. They don't know it anymore. So, and that's my comment as an opening. Just to follow up, let me add one more practical observation from my son's school. At school, in the canteen, they have really cool really nice dishes. But the break is so short, lunch break is so short that my son is only able to make a simple choice, either soup or main dish. He usually chooses the main course, and the soup is a nice vegetable cream, nicely prepared, also very valuable. But physically, he's not able to consume it in this short period of time. So this is another barrier. So there are apples available and vegetable and fruit on the corridor. You can use them, but often they are put to the dustbin and kids don't really see it. But just to follow up and tell you that sometimes there are good practices in our schools, but they are not really well worked out. No, I think we all agree, because we saw it at the panels and the presentations, that education, kids' education, yes, but as it turns out, education of parents is maybe even more important, and maybe this is what we should start with or do it in parallel, because most of parents underestimate the health condition of their children and overestimate their physical activity. Yes. And nobody will look at their children in the same way anymore after having seen those slides. Starting with education and referring to countries which are really similar to Poland. These are sub-Saharan African country, Bangladesh, and these are the poorer countries, but they have a problem with illiteracy, and we have a problem with health illiteracy. And the genesis is the same. In all those countries that I mentioned, and in Poland, kids work really hard. I'm not talking about working in a factory, creating goods. There, they create goods in the form of aluminum elements in foundries, and here we work on for media concerts, TikTok, social media, Meta, 4 hours a day. So kids spend half FTE a day working for social media. If we laid them off, maybe the health status would improve. So they would have a lot of time to have a lunch break and eat food at school. But here again, this is what you asked about health education among children and adults. It's impossible to treat children separately from their parents unless we implement laws that are aimed at separating obese children from parents who caused that obesity and look for them foster home, which is absurd. So we have to work out a solution which will help whole families, because family is the basic cell of social living.
Now, how should we help? There are different ways. First of all, we can start with educating parents. It's about making parents part of that health narrative, showing them that it's not bitcoins or US dollars. That's not the currency, but rather the time that you only spend with your children. Health is the great capital, and capital is something that can be either multiplied or lost. That's how you can approach it in a smart marketing way. So there are ways out, but we won't go very far without parents. So I really liked the presentation about genes. And Kuba Stankowski mentioned very rightly that indeed it's the genes, but it's the genes on the plate more than the ones we have in our bodies. So it's about how we were fed by our parents, what tastes we know from childhood. I still know the scrambled eggs on lard that my grandma would prepare for me. Today I don't eat these things, but believe me, it's part of my identity, that taste. I can't believe you that you never eat scrambled eggs on lard. I do, but just once in a while to remind myself those. Okay. So if you look at how you feed your children, in a way you wire them, you program them, because that will stay with them in the future. So do program your children in such a way that they know what they should eat. We used to have a program with respect to children that go to trips that they should never visit McDonald's restaurants. And that program was quite successful. Indeed, children never went to such trips anymore due to the pandemic of COVID-19. But visits at McDonald's, well, the fact that we teach children at home won't make the waiting lines at McDonald's restaurant any shorter, because those restaurants are available on the same routes that students take to go for different trips. Well, I agree. Indeed, that's the villains. But on the other hand, think about those teachers. What are alternatives for teachers? Where can they take a group of students to feed them? If you go from Gdańsk by the sea in the north to Warsaw in the center, there is no other restaurant that could provide meals to 40 people in 25 minutes. So sometimes to find a restaurant, you have to leave the highway, you have to make a reservation, you have to tell them you will come there. So it's possible, but it requires much more effort on the part of teachers. So, well, I think we should have more mercy on the teachers. If it's just once in a while, then could the children once in a while not go to a McDonald's restaurant? Well, one important piece on adults. We looked at the diet served to patients at hospitals. For example, the so-called diabetic diet served to patients with diabetes at hospitals. Sometimes this is very wrong. I'm looking at you, Professor. I know that we are talking here about some very, very serious issues. So, Professor, I hope that you won't scold us for laughing at these serious issues. Well, we've had 3 presentations that mentioned the same thing, which is if you look at the discrepancy between what parents think and what the reality is really like, then, wow, that means a lot. But first of all, let me congratulate to you, Madam Professor, for all your efforts and for organizing the next round of that study. Thank you also very much for inviting me to this debate. I do have some reflections to share, but before I move on to them, let me discuss some of these outcomes, because they are quite surprising. Maybe we don't realize how huge that discrepancy is. When you talk to patients, when you ask them whether they smoke, whether they drink, whether they eat healthy diet, you probably realize that patients paint a better picture of the reality. And this is what scientific evidence tells us. So we know that the situation is far from perfect. It seems that only every second patient follows the treatment that is prescribed, and the adherence to treatment is only observed in 30% of patients. I'm talking about some permanent adherence. So I guess we could expect that parents are the best ones to really evaluate the activity of their children. We never expected that that bias would be so huge. We don't have the results of the tests here. When you look at other studies carried out among adults, those people that agree to devote their time to take part in a questionnaire normally are better educated in terms of health, that they have healthier lifestyles. And probably the same applies here. Sometimes people said that the device was too bulky, maybe. So I guess we should have a focus study as a follow-up to learn whether parents that declined had a higher bias or not. Maybe it would be worthwhile checking that, whether the same results are reflective of the whole population. Anyway, I'd like to congratulate you, madam. If you allow me, I will be happy to cite these results on my other events that I participate in. And generally, as you know, when we have conferences, off the record, people say more interesting things than on the record. So we talked about this with Professor, wondering what is the most important thing. Well, it turns out that education should start even from pregnancy. And that's actually true. The habits of a future mom, the way, how much she is active and what she eats, whether she's exposed to alcohol, that will wire life expectancy, quality of life of the child, and potential events in their 50s or 60s. And I fully agree that you should be a role model to children. So indeed, they have a role to play. And the example that children see in their parents, in their caretakers, siblings, or even cousins is most important. Healthy choices with respect to lifestyle. If a child sees healthy choices in their nearest and dearest, they will copy them. And if they see poor choices, they will also copy them. And we know that's one of the most important factors that determine life expectancy. It's the family burden. And with all due respect to medicine, still, the most important part of morbidity and mortality comes from the patterns that we receive from our families. It's the family burden. It's inheriting not only of genes, but also of habits. So you inherit habits starting from very early age in life. Starting from kindergartens. So probably children in the preschool age are very susceptible to what they see on the plate, whether they go out every day, whether the parents have time to go out with the child and have some fun in the snow, or whether a child is just left behind with a smartphone or TV set. And then comes the school time, where the role of education is ever higher. And we know that this health education so far has been far from successful. We all counted on it to be more successful. But it's not the case. But we still need to keep trying and keep drawing the right conclusions. I think the idea was not bad, but maybe the packaging could have been better. That's how I would explain it. So maybe we should try to package that content differently, with other colors, so that it's more appealing to the target group. So we need to change the packaging. Maybe the content a little bit as well, but not too much. And once again, let's try to sell the same content in a new packaging. Maybe then that will be better absorbed. I think school education plays a growingly important role with the age in children. It's also about peers. This is the age where teenagers look more onto their peers than onto their parents. Still, health education as a separate subject at school is not enough. It won't solve all of our problems. And Professor said something very important about prices. Well, ironically, look back into the last 20 years, the price of tobacco products and alcohol. It is now better than it used to be, and it's just the other way around with healthy food. Healthy food is now more expensive than it used to be. However, there is now more access to hazardous food choices. And we know that the best form to modulate the behavior of population is by introducing taxes, levies on products. So it's a paradox. We see the inflow of so many new food types, but tobacco and alcohol products are now more available than healthy options. Since we have here the representative of the Ministry of Sports, I'd like to say that in the last 20 years, I understand that the main role of the ministry was so that Poles have win as many medals as possible, right? But that's how I see it, at least, and I can comprehend it. I know that there are benefits in creating the sense of success in society. But I hope that the ministry could be renamed one day into the Ministry of Physical Activity. Not Ministry of Sports, but Ministry of Regular Physical Activity. And sports is just a cherry on the pie. And when you think about interventions, they should be linked with some taxes, with some levies. On top of that, school education, a well-designed campaign in social media, and a targeted approach. I think sports fans are a great case in point. They are not very healthy in terms of their lifestyle. They are disciplined, that's true. But if you put all of the fans into one bucket, maybe, and it will be a huge group, you could change their behaviors. So what I'm trying to say is this. We need a large-scale project for many years to come that will take into consideration different aspects of humans' life, because many aspects influence our condition and our health, and the same applies to children. So taxation, but also tax relief. Think about the cost of different devices. I mean, you can be physically active without devices, you can just jog. Still, if one wants to promote active lifestyles, for some people, some forms of physical activity will demand incurring some costs. So maybe that could be another area to talk about with the Ministry of Finance. Well, Professor, you've been quite provocative, and I just feel I must provide the director with a chance to respond. And me being a journalist, let me just say that, Professor, it all depends on the discipline of sports. I think we shouldn't treat all fans as football fans, because football fans is a loud group that sometimes is seen as the only sports groups, and there are different fans. Indeed. By the way, let me first thank for the invitation and for these outcomes of the study, because I've been using these studies for many years now, and it's great to see that we have such advanced data available. Now let me refer to Mr. Professor's statement, and I guess I will surprise you. Right now, we are working on the strategy of sports development, and the first area that will be addressed is health. Health of the entire population. So the main topic that the current minister is interested in is to carry out a physical education revolution. That's one of the ideas. I don't know if that will be covered in the media, because as you know, media only like to focus on who is the Polish candidate for the next Olympic Game committee. But indeed, we are now working on that strategy, and there is a dedicated website where you can read some more information, and you can also leave there your feedback. We have organized some workshops. Feel free to take part in them. And in recent years, funding devoted to sports, to promoting sports, was comparable or even higher than the spending on infrastructure for extreme sports. And on top of that, since the physical fitness of children is deteriorating, that is proved by many studies. Still, even the Polish trade unions like to say, can you please address that topic? Because in a couple of years' time, there won't be any candidates for future medal winners. And to us, it's a very serious problem for the extreme sport forms. Still, the Ministry of Health also focuses on health and on physical activity in society, and also on teaching those skills and promoting them in society. In recent months, we've introduced to the curriculum a change in the profile of an alumni. And for the first time, some sports-related skills will be included.
And the activity competences, motor competences among small children, classes 1 through 3, are often dramatic, sometimes even earlier. And you can see this based on the outcomes presented today, that the situation is getting worse. And the observation starts in the first class of primary school. If things are bad there, where is the reason? A step before. So, yes, in pregnancy. And I'm looking at it systemically. Where can we reach out to those kids systemically and change something? For example, preschools. And they already have different intervention projects, preventive projects with confirmed positive outcomes. And they should be implemented at an early stage. You've already said it, gentlemen, that we need to start with educating parents. Education is the buzzword. And this is the basis for promoting healthcare or health. And this is what you should start with in all age groups. School or systems like educational systems, preschool. It's a great way of reaching out to big children and parent populations. But also, when it comes to movement, we have 8 basic pluses. 8 investments, as we call it. So strategies of sorts, proven by studies that they do work. And one of the key flagship possibilities is the approach to the whole school, whole preschool, so systemic approach. And thanks to that, when you engage the whole environment, you can impact children, their behavior, their decisions at school, but also on their parents. There's such a thing as reverse heteroeducation. Everybody is nodding their head, you know what I mean. So exactly, that's the point in time when our kids are teaching us something. So a kid comes back from school with new knowledge and educates their parents and says, no, this is not the way you do it anymore. Right? Right? They educate you as well, your sons? Yes, exactly. So they implement what we haven't learned yet, new things, and they can teach us new behaviors as parents. And we've already said it, lifestyle. Dr. Dzielska was talking about socio-ecological model of behavioral change, about health behaviors which are aimed at or which are a key lifestyle element. They are lifestyle. What we do every day, like now, we could get up for a moment and we could stretch because, yeah, we're all very stiff right now, sitting so long. Wonderful, thank you. You can sit now. This is the sedentary time which is interrupted. This should happen at school, in preschool, during lessons, not only during PE. And this is something that's already happening. A lot has been happening with movement. For how long, Mateusz? 2-3 years, and we can see that it started earlier when the previous program started, NPZ and different other programs that were financing projects focused on supporting physical activity and healthy lifestyle, and this is visible. So you can see a change in people, in parents. If you look at big cities, Warsaw, a great example. If you look around, whenever the sun's out, there are so many parents with kids biking and doing other activities. So we're changing our thinking, our daily habits, and that's very important. But the studies have been saying that it's not enough. Our everyday choices and decisions have a negative impact on our body mass, which in consequence results in other disorders. Now coming back to what the representative of the ministry said. The Ministry of Sports is not only taking care of sports, but also physical activity. And now we have this great example. I think it comes from Slovenia. And the sports unions have a duty of searching talents in a given discipline and offering classes in general sports, open classes for kids who just want to move. So, yes, a lesson with a champion. Yeah, something of that sort. So, yes. My colleague from the sports department is just telling me that we already have such programs that are offered by Polish sports associations in volleyball, in handball and others. So it's already happening. And this is taken from other countries. Slovenia is our favorite example. Now, commenting on what Madam Doctor has already said, they paid us a visit, and they said that preschool is the place where you do interventions, and they implement risk play programs that we would do when we were young, and they are doing it in kindergarten, and they can do that in Waver. There is a Finnish kindergarten, and in Scandinavia they follow the same pathway, and that preschool has classes in winter in the open outside, so these kids are actually allowed to go out. They are not really allowed to stay in the class, and we talked before the conference, and the professor was talking about the outdoor activities and about the classes, and I made a review. 94% of kids haven't got sufficient competences. 94%. And going out into the yard, 98% of children are not able to skip on a rope in classes 1 through 3. And a lot of them don't know what such rope can be used for. So they see it and they don't know what to do with it. And to quote something, and I'd like to ask you for a comment. Liza Zappelloni from Rome University. And the problem is that we don't have yards. We can't go out and play. We are actually building a lot of fences. Even sports facilities are shut down tight and protected. Madame Zappelloni said that kids do not climb trees, do not climb fences. They don't have any strength in their limbs and don't have a sense of balance. They are not disabled. They simply have never done it. True. Because we control our kids too much. The parental supervision over kids. Well, when I was last month on a big congress, this was a MOVE Congress, fantastic event with experts in the area of physical activity, and we had workshops. In that workshops, we were supposed to say how kids think, how they would like to move, in which conditions, and the place where there is no supervision, place where there are no parents, where they can do whatever they want. And we can see this in other workshops with Dr. Nadzielska, focused on healthy nutrition and physical activity of kids outdoors. And yes, allocation is not the only thing, but what you do and who you do it with. Kids don't need parents to move, to play, and to do what they naturally need.
Especially the younger the child, the more physical activity it needs. And if we limit the options to choose what they wish to do, the fewer opportunities will be when they choose and opt for activity outdoor. Believe me, going outdoors will also improve social relations of children, which are so difficult these days. It is reported that children and teenagers have a hard time communicating with their peers or striving for common goals. All this today is a problem. And the reason is that children are kept at homes. They never go out. Whenever a child goes out, a parent also has to follow suit, and that's a huge problem. So we talked a lot about how important it is to educate parents and children. Well, I believe we will never preclude any dangers, even if we are like an umbrella or a helicopter parent. Children must be able to make their own experiences. Otherwise, they will be weak. They will never have a chance to experience the world, so they will be oversensitive, and simply will lack these experiences and won't be exposed to some stimuli, and that will lead to more and more problems later on. So I'm sorry to finish off on a negative note, but I'm trying to come up with a positive punchline. So I'm very happy about the activity of the Ministry of Health and Sports that were mentioned before. And in terms of physical activity, movement, and preventing obesity, I think the most important thing is that the work is done between ministries. And this is truly happening. We see some new partnerships built. Also, this Institute of the Mother and the Child, it's a medical institution, and yet we talk about physical activity. So we see that now physical activity and movement are being studied using accelerometers. And I think such studies should be repeated. So these tendencies are very positive. And by the way, thank you for inviting me to this panel. Let me just clarify one thing. In the strategy of sports development prepared by the Ministry of Sports, one can read it's about increasing physical activity of society and improving public health. I know that maybe not every one of us is a fan of Olympic Games, but when thinking about potential organization of Olympic Games, we could come up with a strategy, make sure that this is something that goes across the board. I think then we would be on the right path. I think you still want to say something, right? Well, I won't discuss Olympic Games, for sure. I am not a fan of health education, to be honest with you. I think educating means doing nothing, because just raising awareness doesn't give you a population result. We all know that cigarettes are bad, and still we consume them. So knowledge itself, awareness itself, is not enough. I am a fan of some practical interventions. If a child comes home and says, hey, there is this campaign at school where we will need to cycle to school, and the class that gets most scores will be invited to a cinema. Such a mechanism will be much more effective than just saying, dear children, please spend 15 minutes cycling with your parent every day. And I guess the cost of both interventions would be similar. So many cities in Poland have been rolling out the Cycling May, and I think it's a great initiative where children are asked to physically, to be active physically to go to school and not be picked up by a car. The problem is that we all live in those huge city bubbles. Indeed, huge cities start to organize themselves, and the same applies to smaller cities. However, a huge problem is seen in small municipalities and in the countryside. There you don't have that traditional mechanism by working in the field, because most farmers don't require such work anymore. They have machines, but it's safer for them. So children have no alternatives right now. They have no option to build a good network of social connection. They have nowhere else to go. There is no countryside or there is no yard.
So in fact, that they are left without any alternative for their free time. And I agree, maybe they sleep for 9 hours, they should move for an hour and a half. What do they do the remaining 10 hours? Probably they're sitting or lying down, well, doing something, but it's hard to do anything else. It would be better if they were doing it outdoors, because we are not creating the possibility for them. It's up to us and the state, because we're saying that we will be educating them at school, but unless we give them the opportunity to do that in real terms, that it's like with prevention. Diagnosis without the possibility of treatment, it's actually detrimental. This is my appeal, and it's great that the Ministry of Sports have been doing it. Ministry of Education. So the simplest solution is for classes 1 through 3 or 0 through 3. Physical education, PE, should be offered or run by PE teachers. I know, and it pains me. Let me comment. This is our dream. So I'm not saying it's ridiculous. So yes, it's important to keep repeating. The direction is good, but it's terrifying because they say, well, the teachers say no. But there are cities where it's possible, like the city of Zamość in Poland. There are several such examples where there are extra PE teachers, and it does work. So let's not expect that PE teachers are going to have competences. Early school teachers will have good preparation for movement, for activity. But if we want them to do it, let's prepare them. There are platforms that are available for that. Let me comment, because this is a very cool thing. There is a new curriculum for PE which introduces elements of new physical activity totally differently. There is a plan to apply movement in other subjects, and that's a tendency that's happening. Yes, Madam Professor is going to kill me, and not you, dear guest. Thank you very much, and applause. And let me ask Madam Professor for a short sum up, and if you could close our conference. Thank you. Yes, Madam Director Karne still wanted to say something. Ladies and gentlemen, thank you very much. And one slide is missing, which I was working on for a very long time yesterday. So thank you to the team that calculated how many people were involved in the project implementation. Well, several hundred people, including 26 people from the institute. And in fact, it was nurses, teachers, parents, and at the Medical Genetics Institute. So thank you very much because you've done a huge work. Thank you very much for persevering. And let me say one more thing. I just want to say, ladies and gentlemen, that we should end by talking about challenges. We all say it's great. The Ministry of Education didn't come today. They promised yesterday, but they didn't. Well, maybe it's not a priority for them. The Ministry of Sports, I'm glad they are doing it. The Ministry of Health is satisfied as well. But listen, we have 35% of kids with obesity, and when journalists ask me who's to blame, we are all to blame, each and everyone in our area. Our cardiologists, including Piotr Jankowski, we're not talking enough to patients about the fact what risk factors are. Pediatricians do not measure kids, do not weigh them properly, do not educate the parents. And at schools, I would start with the first classes in schools, because these are the most flexible children. 16-year-old will listen to you, not really. They know their thing, and they will check online taxes, promoting healthy food, rather than implementing higher taxes. A highly processed food is the cheapest. You go to the store and you see what people are buying. Infrastructure in local governments, safe pathways to school, where electric scooters are banned. So regulations, legal regulations, legislation concerning safety on the roads, admissibility of sports facilities and trainers. The fact that a child goes running by itself in a sports facility, there has to be someone who's going to train them. So briefly speaking, we've set the targets and the tasks, and I do hope that the next COSI will have better outcomes. Thank you very much. Well, I'd like to thank Madam Professor for your wonderful organization of this conference, and we got a lot of knowledge, and well, let's hope that everything we talked about will enter into force. So thank you very much. Dr. Dzielska, who participated very actively in all those studies, so thank you very much indeed. Thank you very much. Thank you for the invitation. Ladies and gentlemen, thank you for coming, and officially we can close our conference. Thank you and have a great day.